Good morning to everyone. This is the Health Insurance Affordability Task Force. Appreciate the task force members being here. I'd like to recognize that Senator Crum is en route to watch his son participate against the Falcons, I think, this week. And but will be joining us as his reception will allow. Chairman Nethercott is here, had to step out for some issues on her work and will be joining us shortly. And with that, Anna, could we go ahead and go with roll call?
Good morning, Mr. Chairman. This is for the Health Insurance Affordability Task Force for August 13th. Senator Crum.
Present.
Senator Love.
Here.
Representative Geringer.
Here.
Representative Pendergraft.
Here.
Mr. Boley.
Here.
Director Johansson.
Here.
Mr. Red.
Here.
Commissioner Rude.
Excused.
Ms. Williams. Co-Chairman Nethercott.
Temporarily excused.
Chairman Larson.
Here.
You have a quorum, Mr. Chairman.
Thank you. For those who are attending from the public, we just note that as we begin the meeting, we want to call your attention to the committee's rules of decorum. Copies of the decorum rules are located with hard copies of the agenda if you have those, and are available for view on the legislative website on the page for this meeting. We note these rules at the beginning of each meeting simply as a reminder that we expect everyone in attendance to be treated in a courteous and respectful manner. Chairman Nethercott and I take these very serious and will preside in accordingly. But with that said, we'd also just like to say thanks to each of you for being here, committee or task force members for taking the time to look and read and prepare for this meeting. And for those of you in the public that are going to be providing testimony, we know that it takes away from your productivity in your life, and you set that aside to be here, and we really want to say thank you for being here. If you haven't signed in, attendees, please do so. And we'd like, as first order of business, we'd like to look at the minutes from the previous meeting and see if there's any questions or corrections, and if not, approve those. Thank you. Second. Moved by Representative Geringer and seconded by Senator Love. So those are taken care of. Our first item of business today is regarding Title 25. This was a request made by Chairman Nethercott at the previous meeting, where the hospitals noted uncompensated care and talked about how some of that comes through Title 25 placements in hospitals, where the costs to take care of these people exceed what they're paid for. The question was asked on whether or not private insurance could also cover those costs for people who have private insurance, and is that an appropriate request? We talked about some of the legislation we've done in previous sessions, and have asked Franz Fuchs from the Department of Health to remind us of some of those efforts. We've also provided in this packet 25 LSO, which was 2 years ago, 0030, and Anna will talk about that draft here in a minute. So Franz, if we'd like to turn the time over to you, please. And committee, yeah, today is just, please let me note as we'll go through the presentation if you have a question, and we'll just interrupt Franz as we go and ask questions. Thank you. Franz.
Thank you, Mr. Chairman. Good morning, members of the committee. My name is Franz Fuchs. I'm the Deputy Director at the Department of Health. Came here today regarding Title 25, not to speak to any of the legal nuances, but really kind of give a bit of an overview of the fiscal side of how, who pays for what, kind of what the total cost trend has been, at least from the Department of Health perspective. So I'm not sure I can answer too many detailed legal questions. I'm not an attorney, and hopefully we have some excellent attorneys in the back that can hopefully answer those kind of questions on the nuances of Title 25. But just to begin with a brief overview, Title 25 is really intended for civil commitment, involuntary hospitalization. So people that are demonstrating a danger to themselves or others, generally speaking, their first encounter will be with law enforcement. And at that point, they may be detained. They may be taken under 25-109. There's this emergency detention proceeding. And if that continues, there's various legal hurdles for both law enforcement and the judiciary to cross with the judge. Ultimately, if they get titled, which under 110, which is the relevant statute, they will enter into our custody one way or another. And generally speaking, the first destination or the preferred destination is the Wyoming State Hospital. We have our adult psychiatric services wing. Our current census right now is we have about 40 people that have been there for over 180 days, an additional 26 people that have been there less than 180 days. So around, fluctuates around 60, 70 folks on the adult protective services. And unfortunately, that census and the staffing limitations that we've had in the past means that we typically have a wait list. There's typically more demand for involuntary hospitalization beds than there is supply. And our wait list, again, waxes and wanes. Just last month, it was 11 people. Today, it's 6 people. So it certainly goes up and down. But what does that mean when somebody's on the wait list? When somebody's on the wait list, we typically will contract with what are called designated hospitals. And those are, by and large, the big players are going to be WBI in Casper. Wyoming Behavioral Institute in Casper is the lion's share of that volume. But there will be smaller psychiatric wards around the state, like Cheyenne Regional occasionally, a couple other places that will maybe we'll pay them a per diem to essentially hold somebody on the wait list in a secure environment. We pay those hospitals $630 per day for that service. The distribution of those costs, generally speaking, the statute kind of talks about that in section 2510-112, the liability of the costs. And generally speaking, the county is going to be responsible for the first 72 hours of that detention, and then the state picks up the tab for the rest, for as long as that person is detained and until there's a bed that opens up for them at the state hospital. We don't have a lot of visibility on what the counties pay. All we really know, what we see, is when somebody is titled, we sort of get those court orders and we track those, and so we can track the wait list from the point they are under that 110, 2510-110 involuntary hospitalization. But we really don't see the volume of emergency detentions that are happening throughout the state. So we don't understand. There's obviously a funnel that happens, right? Not everybody who has an emergency detention ends up with a title. So there's some amount of 109 hearings that happens and county costs that are incurred in the emergency detention phase. But we just don't have any visibility over that. And that was germane because one of the proposed bills, I think, from the Mental Health and Vulnerable Adult Task Force was to have essentially hospitals bill the Department of Health for those, including that first 72 hours. We would be able to track that data, and then we would invoice the counties to basically recoup the costs of that first 72 hours. So that was a proposed bill draft that happened a couple years ago. But as things stand now, all we see are the Department of Health's cost. And I just wanted to share my screen, if that's okay. I wanted to show you kind of what the trend has been. We've been tracking this for some time since it became I think we have almost over 10 years of data here. Okay, so that's not very helpful. It's very small. What you can see, I guess, with those spikes so each of those spikes is the cumulative cost for each biennium. So we go back to 2012 and that first biennium there ending in I think in the mid-July of 2014. And so you can see that kind of spikes at around $10 million. Now this Title 25 kind of came to a crisis because in the next biennium, you can see that spiked up to almost $18 million. And we don't have a budget to pay for Title 25, or we didn't at the time. So this was kind of coming out of our state hospital budget, and it was becoming a problem, as you can see, that escalating cost trend. And so there was a significant amount of legislative interest, some task forces that were formed to try to figure out what's going on. Ultimately, what we did, and let me just back up a little bit. Back in those days, the olden days, what happened was, these designated hospitals would send a paper claim to the state hospital, and that state hospital would essentially just pay these claims. Very inefficient, very little oversight of who might have been responsible for those costs. So it was a pretty archaic process, and the people at the state hospital are very, very good at dealing with psychiatric patients. I will say not so good at processing healthcare claims, and we just had possibly a lot of that overrun. If we can't identify who may have been responsible for that claim, a phenomenon called third-party liability. All those costs were accruing to the state, and we were paying those basically with paper claims and checks. The big policy response, I think, that's provided a lot more oversight and a lot more transparency in this data has been we moved all the Title 25 claims processing into our Medicaid claims processing system. So now all of the claims are processed electronically. We determine whether or not Medicaid can pay for that claim because for example, for kids, anyone under, I believe, 18, possibly 21, I'm not sure what the cutoff is for psychiatric hospitalization, but if they're considered a child and they're in a psychiatric hospital, Medicaid can pay that claim instead of the state general fund, meaning that we save 50% on the state general fund basis and the feds kick in 50% for that. So that's done automatically because now we're screening all these claims through Medicaid. But what we also allowed is us to match the person's information with a database that we have for Medicaid purposes on third-party liability. So we contract and we gather data with big insurance companies, Blue Cross being one of the biggest, but also the state insurance plan, other big payers in the state. And we determine whether or not that person is insured privately and whether or not psychiatric hospitalization would be a covered benefit. Title 25, 112 does specify that hospitals are really to look for outside pay sources before they bill the state. And so what this enables us to do is basically bounce back those claims and say, no, we believe this person is privately insured. You should go bill that insurance first before coming to us. And so through a combination, I think, of increased oversight, the Medicaid and third-party liability offsets, and just increased scrutiny on this system in general, our cost trend has been moderated somewhat. It does fluctuate year to year. You can see last biennium we were just over $12 million, but this current biennium we spent $7,366,823.56 on psychiatric hospitalization and associated costs. This is kind of the projection trend that we use. This was done in April. We kind of try to project because we don't really have a solid budget and the claims are, we don't control the spigot, right? The courts control the spigot. We just end up paying for it. So this is kind of our best effort to try to project from the beginning of the biennium to the end of kind of where our claims will be.
Mr. Bully?
Thanks, Mr. Chairman. Franz, going back to the daily rate, sorry, going back to the $630 per day, can you explain how we arrived at that dollar amount? And then secondly, if that patient were cared for in the hospital in Evanston, what's the daily allocation and what does the state pay itself for caring for that patient?
Sure. Mr. Chairman, Mr. Boley, that cost is basically arrived at. We have looked at mostly WBI's cost reports, and we have said, okay, what are their costs regarding inpatient hospitalization, and we sort of pay a little bit. We have historically paid a little bit above that. I don't know how it's kept in the past couple of years. This was last rebased in 2024, I believe. But that is kind of the methodology that we've used to set. So they take all their costs that are allocable to specifically to inpatient hospitalization. So we subtract all their costs relating to potentially to like the PRTF side of things that they run and a couple other lines of business. And then we divide by the patient days that are in that facility. And so that's an average cost per day as we understand it from the cost reports. And we kind of set our rate historically based on that. And then if we need to rebase it, we will bring it to the legislature and say, hey, this is what the cost trend has been. This is the request from these designated hospitals. We request an increase from 630 to whatever. And this is the budget impact that we anticipate. Now, your second part of your question is what's the average cost per day at the state hospital? That's a good question. I think it's around $1,200, $1,200 or $1,300 on an average cost basis per day. And so that's basically when you take our total expenditures and divide it by our total census and patient days, that's kind of what you end up getting.
I don't know if you know this answer, Franz, or not. Do you know what the counties pay per day? And it's probably all over the board in each different county, right? But it'd be interesting to see if what the state's paying is even close to what the counties are paying for their 3 days.
Mr. Chairman, Mr. Boley, I think it does. You're absolutely right. It varies all over the map. We don't know exactly what their negotiated rates are. I think some counties have better deals, right? If they, for example, might own the hospital and they get it for free, right? They get the psychiatric hospitalization, they pay nothing potentially to paying bill charges or some percent of bill charges. So it's definitely all over the map. But one point I want to note about this whole system, regarding the cost per day, right? The state hospital is from the state's perspective, a fixed cost. If our patient volume were to decline, if we didn't have a wait list and we only served, say, 60 people, we would still employ the same number of staff. We don't flex our state staffing according to the volume. And so we're not going to fire a bunch of nurses because our census just happened to go down. So from our perspective, we pay the state hospital, it's a fixed cost that essentially is relatively fixed regardless of the volume. Whereas the Title 25, what you see here, these costs are, from our perspective, a marginal cost, right? If we can reduce the wait list to nothing, if we can essentially serve all of the patients at the state hospital within our current capacity and reduce the demand potentially upstream, that would drop to nothing or some safety valve amount, which would be in the hundreds of thousands of dollars. So just a little bit different. I know from WBI's perspective, it's a little different, but from the state perspective, we see the state hospital as a cost we have to incur because we don't have the flexibility to hire and fire staff that rapidly. And the location is set by the Wyoming State Constitution, so it'd be difficult to change things like that. That said, at the end of the day, we do try to minimize our marginal cost here. And, most of our efforts have focused on the community behavioral health system as really trying to say, hey, can we step up on the community side to divert these folks, to prevent them from entering the system when they discharge from the state hospital, to keep them from cycling back into the system, because about 30% of the volume is going to be people that just keep going through the system over and over. There's a lot to be said that, can be a lot of work that could be done on that side of the house to really try to prevent a lot of this volume from happening and keep the state hospital under its capacity limit.
So Franz, I think part of the conversation, at least in my perspective, that we've overstepped is going back to this conversation on the state hospital. The state hospital's full, so we use designated hospitals. That the designated hospitals like WBI are generally only used after the commitment's been confirmed that they're at risk of hurting themselves. So then we have that first 5 days or so while you're waiting for a determination from the courts on what to do with them, and the placement of those people in that period of time are generally just at our community hospitals. Some maybe it would be nice if some could go to community mental health centers, but for the most part, I think for this conversation, the first 5 days or so are spent at our county in local hospitals. And so then I think the conversation has been, they too have to keep nurses 24. They don't fluctuate their number of employees up and down because they have to stay open 24 hours a day, 365 days a year. So then the conversation on the reimbursement rate really has been around that first 5 days and what we do there. And how do we, I guess my question to you is am I seeing that accurately? And then what we tried to do in the bill in the mental health and vulnerable adult task force is to the hospitals were saying, I think there's two arguments that one, the hospital isn't getting paid from counties, and then the other part was that the counties are saying we're getting charged too much. And so maybe Director, I know your last name, Stephen Johansson. Director Johansson, would you do you want to take that a little further, and then Anna will have you fill the gaps if we need to.
Mr. Chairman, thank you. Just one minor clarification. So in what Franz mentioned with how we pay on the psychiatric side for whether it's WBI, Cheyenne Regional, Ivinson, hospitals that have psychiatric beds would be considered those designated hospitals that handle the overflow when the state hospital is full. In addition to that, for folks that are held in an emergency department or on outpatient observation in a county hospital, for example, we pay essentially on a fee schedule, like professional fee schedule, generally mirroring the Medicaid rates, which folks have strong opinions about, as you can imagine. So it's not that there's no reimbursement for folks. Again, when the state takes over payment after the first 72 hours, we will pay the per diem for facilities that are using and have those psychiatric beds, plus professional fees, which again relatively speaking, don't generally amount to the bulk of the costs. But for a general hospital, North Bighorn Hospital, whatever it might be, where a Title 25 detainee is being held, awaiting either a bed at a designated hospital or a bed at the state hospital, there is reimbursement for that. And to Franz's point, it also, when we get the claims, we can run it through Medicaid eligibility screening, third-party liability, those types of things. But you're right. Your second point, there's always been some amount of dispute, confusion, whatever you want to call it, among counties of who should pay for what, which county is responsible, county of origin or county of where the person is from. It really is a mixed bag of different sort of logistical problems around the state. But in terms of the previous bill from the Mental Health and Vulnerable Adult Task Force, as Franz mentioned, the idea was to run all of that through the state. So counties, instead of receiving bills from various hospitals looking for the first 72-hour county funds, would just have a one-stop shop, send all the claims to the state. We would do the work just like we do after 72 hours to determine any third-party payers that could offset the cost. But also then I think the idea at the time was the state would set the rules of the game, would set the reimbursement schedule in those first 72 hours, pay those providers, and then essentially charge back the counties. Here's what you owe for that first 72-hour period. So on the pro side, in terms of that previous bill from a few years ago, financially and logistically, the system gets more efficient. We take the billing burden and the claims adjudication burden off of counties, and I think everybody recognizes some relative business efficiency there. The downside, as we discussed at length with various stakeholders and with that task force, is you do then kind of remove some of the creative arrangements and local control that can happen where, and it might prevent folks from wanting to participate in a consolidated system because they've worked out a good deal. They have a certain number of beds or access that they can get on a more rapid basis. And that's kind of the pro and con that the committee at the time, the task force at the time was weighing. So I think it's important if we're, considering that again to weigh those. And my recollection, might be just my recollection, was that bill ultimately didn't move forward for those reasons. Everybody recognized the benefits on the financial and logistical side, but was the juice worth the squeeze? Would we have enough participation? Did the county governments certainly didn't want to be compelled to participate in the system at the time? Those were the balancing factors from my memory.
Thank you, Director. And then, so that we really don't head down a path on whether this is a bill that the task force would need to reconsider or not, we certainly could if we so chose. Anna, is there anything else that you would add in the structure of that bill? And the question I think that we're trying to answer today is there the ability to use private insurance to help cover those costs? And what I'm seeing so far is yes, and we're doing that. And so as we bear that request from Chairman Nethercott last night on that possibility, I think what we're hearing is yes, and kind of calling a stop there. Give me just a sec, Franz, and then is that something? I think we're just trying to answer that question today. So I'll go to Anna first, then back to you, Franz. Anna, is there anything else you'd add to this?
Thank you, Mr. Chairman. The only thing I would add is I remember the bill allowing counties to opt in, whether or not they wanted to do this arrangement with the Department of Health. Other than that, I think the gist of the bill has been covered.
And interestingly enough, the opt-in was, we heard from some hospitals like Niobrara County who says we're willing to pay a higher rate because this hospital is really important in our county. It's a county hospital and we need to do that. Other hospitals were not as inclined to be that generous. And so that's why the opt-in and opt-out thing. And then we didn't move that forward. Franz, back to you.
Yes, sir, Mr. Chairman, and I apologize, I was doing that background, but I buried the lead. The lead of my testimony, the main point I wanted to make was in all of the system, the amount of Title 25 third-party liability that we've collected is $264,095.67 over the last biennium. So that's about 4% of the total state costs. So I would submit to you that the third-party liability is a relatively small factor in Title 25.
Okay. Questions? Okay. Anything else, Mr. Fuchs?
Mr. Chairman, just happy to stand for any questions.
Hey, well done. Brought back a few memories. I had to remember how that bill went and why. Mr. Boley, if we could have you next. You recall members that we had last time, the Hospital Association had provided us with a document that was titled Making Healthcare More Affordable. That was a work that the Hospital Association in conjunction with the American Hospital Association had put together, identifying ways to take the pressure off hospital costs and medical costs as a whole. We've asked Mr. Boley to make some recommendations from that document on what we might consider as we move forward. In this conversation, we also had Eric called and asked if I would visit with Ready Health, who is a consulting group out of Utah who work solely with rural hospitals, I believe, and has been helping several of those in Wyoming understand their cost measures and cost drivers. And we'll be hearing from them as well at my request. So, Mr. Boley, the floor is yours.
Thank you, Mr. Chairman, committee members. Eric Bully with Wyoming Hospital Association. And I did sleep very well last night as I thought about what I wanted to say. And I'm a little bit hesitant to share a personal story, but I think it adds to this conversation. And I don't really like to bring my family into the public, but for the past several years, my son has been struggling with a chronic illness. He lost 2 years of school, had to be homeschooled because we couldn't get it diagnosed. We started here at our local hospital, had referral after referral to different specialists. Some specialists took 2.5 months to get into. In the meantime, I have a 13-year-old boy that can't get out of bed because he's so ill, and he gets out of bed and he end up on the floor in excruciating pain. We finally got it diagnosed, and he's had to undergo a series of different tests, a lot of EGDs, endoscopies, a lot of colonoscopies, and he has an autoimmune disease that he'll live with for the rest of his life, and it came out of nowhere. We're lucky, we're insured, and we jumped through all the hoops that we had to with the insurance to get prior authorizations and things. But what I would say is the system is pretty broken, and I feel for the patients, and I feel like we can do better. And that's what I hope comes out of this, from the hospital and the healthcare side to the insurance side. What I would share with you also is that my son had to go through another test, and other than colonoscopy, there are less invasive procedures that can be done or tests that can be performed. So we went through the process, and my son was prescribed this test. We got prior authorization taken care of, and we had the test done at home. We delivered it to the local lab, and 2 months later, I got a bill from the hospital that the test was not covered, even though we had prior authorization. And so we went back to the hospital and said, 100% prior authorization, you need to take care of this. In the meantime, we start getting billed, and we get threats about collections. And so we get on a payment plan. And luckily, I have a good relationship and an understanding of how the system works. And I worked with our insurer on this issue. It was almost 9 months from the time that my son's test was conducted till the time that we got that prior authorization situation rectified. The hospital had given up on it, and it basically said that it was our responsibility. And I'm grateful that I had that relationship and I was able to work through that and eventually get that paid. That's just one example of what happens on a day-to-day basis in this industry, and I think we can do better. So with that said, as I take a look at the recommendations from this blueprint for lower costs from the American Hospital Association, I'll also share one more story with you. There's a group in this state that is attacking associations, and we've recently been attacked, and I've been accused of being a puppet for the puppet master, which is the American Hospital Association. And it's being said that we are taking model legislation and bringing it into the state that the American Hospital Association is pushing forward. I would tell you that is the exact opposite of what actually happens. This document that you have before you, State Hospital Association executives, CEOs from hospitals, doctors, all kinds of staff, we're split up into 9 regions within the country, and they're called regional policy boards. We meet 3 times a year and discuss what's going on. We're the ones that came up with these recommendations that were then sent to the American Hospital Association and their board, and these were deliberated. These are the solutions that we've come up with and that we've suggested, and we're the ones that are pushing these ideas. And unfortunately, in this list, what you're going to see is a lot of stuff that needs to take place federally. As we found out last time in this meeting, only 15% of what happens with insurance companies does the Department of Insurance really have any regulatory authority in our state. And realistically, it's such a big industry that we need federal changes. So I think there are some great opportunities in here. And if you look at this, we're not pointing our fingers at anyone. What we're trying to do is come up with common sense solutions to drive down cost overall, because it is expensive, no matter which side of the equation that you're on. I would, though, draw your attention to strategy 1 and talking about improving transparency of pricing information. Last year, we successfully passed the hospital pricing transparency bill. And you'll remember the year before it was considered, but we also knew that there was executive orders that were still coming, and there were changes to be made in that program. And that's why we advocated for waiting until the dust had settled. So we passed this bill with a lot of cooperation from all of you. And then just recently, Congress has actually acted, because everything was done under an executive order, and now Congress is acting on codifying that as federal law. There's a lot of great work going on in some of these other things within our state too. Hopefully you're all aware that 2 days ago we met in Casper and we awarded almost $205 million through the Rural Health Transformation Program, and a great deal of that money went towards primary care and access to primary care. And so where we can do it, we are doing it on a statewide level. There's talking here about reforming medical liability system, whatever that might look like. Again, it's a national push, and it seems to have some traction. What we also worked with the insurance companies that we could work with here within the state in the last several years, and came up with some prior authorization legislation that I think is actually very good and has been used in other states. We worked on the credentialing process to expedite credentialing and enrollment for new providers that come into the state so they can start seeing patients quicker. One idea that has bounced around twice now, and we thought we were going to get it across the finish line in the last session, but we've introduced and worked on an international physician bill, and it's not a huge silver bullet, and there are some major barriers that have been put up recently with the cost of visas and foreigners coming into the country. But I think that's another solution that might add a little bit more primary care into our state, even if we were able to bring in 4, 5, or 6 well-trained, highly vetted physicians from foreign countries. And so we're hoping that that might come back again this next year. Rural Health Transformation also provided a great deal of money to 2 universities to increase residency slots and to help bring more physicians through that process and work in Wyoming. And we hope that that can continue over the next 5 years as we use the additional rural funding that will come in. And we kind of think that there should be a look also at how we can encourage and bring in foreign nurses and other professionals, because we're just not producing enough within the country or within the state. And then finally, I'd like to go back to my son. So he is doing better. He's been prescribed a drug that we all get to see advertisements on every time we watch a football game or a basketball game. The cost of that injection is $4,500 a month. And I shudder to think what will happen when he's not on my insurance, if he's able to get insurance and get coverage, but how is he going to afford that? And that's really the only thing that's allowing him to live a quality life right now. There's hope that by the time he turns 26, which is 10 years from now, potentially there'll be a generic out there, but we really need to do something with pharmaceutical costs. And I know President Trump's been working on that, but that's another one of the big recommendations that we think is super important. And every night, if you watch TV, 2/3 of the advertisements on there are catchy jingles and these brand new drugs that have come out. And I think that there's some work maybe we can do within the state to help bring down some of those costs, but most of this is a federal thing. And so I think we've been trying to do things that we can within the state to impact it, but most of this is federal. And I would say hearings like this are happening all the time back in DC. Congress has been holding hearings with hospitals, with insurance companies, maybe with pharmaceuticals a little bit, and I think they're starting to tighten up on that. But I'd also say there's a lot of money flowing into our state from big pharma and others to shoot down good ideas and to push those ideas out of our state that could really help. And I do think that the next 5 years, there are some areas with rural health transformation funding as we get through this first year and as we modify our approach that can really help us to drive down some of the costs in our state. And again, I think one of the other areas that we're really seeing a lot of advancements and where I think rural health can really help us out is in the use of technology. Technology is really changing when it comes to AI and other things. There's good and bad in AI, but it's incredible some of the tools that are available out there. And if we can get that funding through rural health transformation, I really think that we can set ourselves up for a better future as we transform healthcare in the state. With that, I'll close my comments unless you have any questions on the recommendations that came through the regional policy boards of the American Hospital Association.
Questions for Mr. Boley before we move on? I'd like to, as we get into this conversation a little bit, just remind the, excuse me, the task forces that there's some, to Mr. Boley's comments, which we really appreciate, Eric, is we've got to formulate and separate some things out in our mind. And one of the things that we look at as we try to find solutions on the rising costs of premiums, which then come back and are impacted by the high costs of medical charges, is it temporary or long-term? And does it fall within the role of state government to do? I think there's, as we talk about the rural health transformation, it's important to remember these are wonderful things, but it ends in 5 years. It's one-time funding unless we do something else in the meantime. So as we look at things that can be implemented immediately, things like the rural health transformation provide opportunities that we need to take advantage of, and I believe we are. But we also have to be in our minds contemplating what we can do long-term to impact or slow down those costs on insurance. And so these are all good conversations, but we just kind of have to, I'm just asking the task force to kind of sort them and put them in their various bags as we have the conversation, because it's easy to get hooked up and say the rural health transformation and life is good for forever after, when it just isn't. However, if we think about that rural health transformation model and the Department of Health's effort originally in the application to create a corpus, a fund that we could set aside and use the investment income like we have and that you all talked about in appropriations, and then use that revenue to then sustain these programs that we're talking about. That can't be forgotten either, because even though we couldn't do it with these federal funds, the idea is very valid, and maybe then we look about using general fund dollars to set up these corpuses over the next number of years, just like we did with the WWNRT and the Cultural Trust Fund, and of course the Permanent Mineral Trust Fund. And I just think it's important as we talk through the rest of the day that we contemplate how maybe a short-term could become a long-term, or keeping short-term solely short-term, and then looking at ideas in governance and other issues to mitigate the long-term impact. So thank you, Mr. Boley. And I did have one question too, after I pontificated there for a while, is on your primary care and prevention, you note that we're doing some stuff, but in your document, you talk about access points through innovation partnerships. And those are wonderful words, but do you have any specific ideas, or there's something out there that you could say, yeah, that makes sense? Is there anything that we can start working on primary care now that you've identified?
Mr. Chairman, I think that's a great question. I think we kind of did identify that. The federal qualified health centers are
Say that again, please.
federally qualified health centers, FQHCs. They're present in our state, but a lot of the rural health transformation funding went towards increasing those programs and increasing access to primary care. We also think that potentially it can really help us with some of the OB desert issues that we're seeing in the state. So we've already kind of started down that path, but I'd like to echo your comments. At about 3 o'clock this morning, I was thinking about the perpetual fund and what that could mean, not only to securing or sustaining our small critical access hospitals in the state and some of our larger ones too, but also how that could impact the overall cost of healthcare and potentially hopefully drive down premiums. I really think that there's a lot of value in continuing that conversation to look at setting up something within the state. I applaud the Department of Health and the governor's office for trying to get that passed through CMS, but I think there's an opportunity there.
So on the FQHCs, the Federally Qualified Health Centers, Director Johansson, this may be to you. Could you just help us in what the approach was with the rural health transformation and help us understand? I believe that they get a higher reimbursement rate if they're federally qualified. And then explain that structure and then help us understand what the potential was with the rural health transformation.
Mr. Chairman, I'll be brief, but happy to answer any questions. So broadly speaking, all of the initiatives that we proposed and that worked with the Appropriations Committee in the Legislature to codify in our rural health transformation plan were rooted in quantified feedback from town hall meetings in small towns across Wyoming. Access to primary care, and ideally primary care that's integrated with behavioral health, was one of the top public priorities if we were to invest in rural health care around the state. So with that being one of the top priorities, we proposed this model of using the rural health transformation funds to expand and invest in federally qualified health centers that are primary care providers, because not that their funding model is perfect. I think you talk to any director of an FQHC who will say, we have problems, we have staffing issues. This is not, it's certainly not a silver bullet to say every FQHC can operate in the black, no problems, et cetera. But relatively speaking to, primary care provider that hangs a shingle out and operates privately, can be a more sustainable funding model because of how their funding works in this sort of federal qualification, federal program. In addition, this is something we heard a lot from our legislative committees over the past several years, that one of the contributing factors to the problems in sustaining OBGYN and labor and delivery services around Wyoming is the high cost of malpractice insurance and liability. That is something, again, not perfect, where FQHCs do fall under federal tort protection. So that was another reason that we wanted to start in this first year of testing what we would see in applications for this particular initiative in rural health transformation in the model of the federally qualified health center. It's very fair to say, not just in this initiative, but in all of the initiatives, we've received in the past several months a lot of feedback. And some folks and providers and communities that were upset that this was narrowly, many of our initiatives were narrowly defined, narrowly eligible. And that's fair. And so, as Mr. Boley mentioned, with the advisory committee that had its inaugural meeting on Tuesday in Casper this week, we'll certainly be looking at opportunities for year two to maybe tweak, make modifications within federal parameters to look at other types of providers, rural health clinics, particularly in this primary care initiative, that could be eligible in year two. But it's really important to mention across rural health transformation, and Representative Pendergraft knows this well from a lot of discussions that we had in developing what was ultimately the state statute in the bill. that directed us to negotiate with the federal government, we have had a very intensive focus on sustainability, knowing that these are temporary federal funds. So while there might be really good ideas, worthwhile projects, et cetera, with our lessons learned from ARPA and CARES Act and other federal funds that have fallen out of the sky over the years, we know that often state decision makers are left after the grant period with saying, well, now what do we do? Is it a general fund appropriation, et cetera? So with that focus on sustainability, every applicant that we worked with or that we saw in rural health transformation and that the advisory committee saw this week, I think that was a common theme of we might all want to fund this and do this, but what happens in 5 years? And that really goes back to the idea of that perpetuity fund that we weren't able to get approved at the federal level within this program. But I think certainly for a state like Wyoming, very large space, small population, difficulty with scale, and also difficulty when you have this kind of money, how do you spend it effectively in the period of time that's so rapid? Certainly from my perspective, has merit in funding smaller amounts, but with a longer runway, so you have that sustainability. Mr. Chairman, hopefully there was an answer to your question somewhere in that response.
There was, thank you. But just to help us keep things in the right lane, when we talk about FQHCs, those are all hospitals, is that correct? So you could be a private provider, not associated. Tell us what qualifies for an FQHC. And the reason for the question is because we heard last time that it's access to primary care generally comes through your primary care physician. You go to his office and receive that primary care, and that's at a much cheaper cost than going to a hospital. And then we start talking about the monopolistic nature of life if medical entities come in and want to consume all of those private practitioners too. How does that play in? So that's the rationale behind my question.
Mr. Chairman, thank you. At the risk of butchering this, so folks listening online that work in this system, forgive me, but I'll speak generally. Federally qualified health centers are not hospitals. They're kind of a specific model of almost all-encompassing primary care that has to meet federal requirements for the types of services that are provided, kind of an array, a menu of services, as well as treating and accepting vulnerable populations and charging on a sliding fee scale. So there's kind of a financial access, but also requirements from Health Resources Service Administration or HRSA of the types of services that have to be provided. By nature of doing that, becoming certified as a federally qualified health center, you essentially as a business agree to provide those services. And there's a certain funding model that comes with that if you meet those conditions. So hopefully that's somewhat clear, but again, very general perspective. Happy to follow up with more detail.
And the number in the state?
Mr. Chairman, we can get back to you very quickly on that.
I think it's, thank you.
And Mr. Chairman, I think it's 9, isn't it? Somewhere around there. But they can also be good partners to our hospitals and to their clinics because of their funding model. There's the ability to take some of the stress off the hospitals, especially when it comes to the insured and uninsured.
Fair enough. Representative Geringer.
Thank you, Mr. Chairman. Going back to the blueprint, Mr. Boley, I wanted to kind of get your feedback a little bit more on of the things that the state is able to actually do and implement. What in there are some of the top things that we really could do that maybe we aren't already doing that would have a measurable impact for us and doesn't get qualifying that with not shifting any of the burden to the taxpayer, but just reforms that we can do or programs we can do or anything like that may have some of the larger impacts. I noticed one of the things in there is tort reform. Do we need to be discussing that? I know there's not a lot of appetite to discuss that. Is that one of the things? And I'm just throwing that out there as an example. I'd love to hear your feedback on that. What are some of the top programs, top ideas there?
Mr. Chairman, Representative Geringer. So I think tort reform is an important conversation. I know it's not a popular one. There was an attempt 20 years ago, I think, to put it on a ballot. But it is a hindrance especially in recruiting OB doctors into our state, and you'll hear that from them and reasons that they're leaving the state. We've tried different models. There used to instead of tort reform, there was a panel that was set up where before a lawsuit could be filed, it had to go through this panel to be studied for its merits, and that I think it still exists on statute. Was very rarely used. I think maybe half a dozen times. And I don't know even know if I don't think it really operates the way that it used to, but there was a thought that to make sure there weren't frivolous lawsuits, they would go through that process before it could actually, I think that's right. Is that right? Medical review panel, yeah. But does it still exist, Chairman? Yeah. So I think it's something that we probably could discuss, and I think there's some efforts through the Joint Labor Committee to take a look at a different type of model to work on this. I think unfortunately most of the things that we have been able to identify from this list that we can work on, we have been working on in the state, and that's the hard part is we're dealing with 1,000-pound gorillas, the Uniteds of the world and others, where as we look at administrative burden and gumming up the works, denial rates and prior authorizations, it requires so much manpower. And I think these guys will kind of talk about what they've seen as they've worked with our critical access hospitals and what that process looks like. But as Medicare Advantage has, and I'm getting off on a sidetrack, but just as Medicare Advantage has come out, United is one of the biggest players. And there have been well-documented articles about this. 50% of the prior authorizations for that treatment were automatically denied without even being reviewed. And it was done with algorithms used by AI. Of those 50% denials, 80% were overturned once they were appealed. But there's this practice of denying, delaying, and then defending. And so an example that I would use is when the hospital was built in Saratoga a few years ago, we had a Joint Labor Committee meeting there. And in the afternoon, we went to tour that new hospital. They'd only been in existence a few months. There were 4 people sitting at the front desk. One was the receptionist, and there were 3 other people on the phone. And what we found out was they were nurses, and they were on the phone 8 hours a day working with the insurance companies to try and get prior authorizations, trying to get denials overturned, and working on the appellate process. There's an important part of prior authorization, I think, in reviewing claims. But we've got a shortage of healthcare professionals, and we've got those folks that are spending their time when they could be caring for patients and when we're looking for RNs and other nurses. And so, and it costs the system on both sides so much money. And I'm sure there's money that's saved by looking at those prior authorizations. But I'm grateful for what we were able to do within the state to try and expedite that process and work with those that we could. So.
Okay, sorry.
So I think we've tried to address what we can. A lot of it has to be done federally.
Thank you, Mr. Chairman. I think the good representative next to me here was looking at my notes and wanted to steal some of my thunder. Yeah. Back to tort reform, and that's obviously one thing that I would like to think maybe at the state level we can do some good. But you and I had a conversation a day or two ago, and I mentioned this, and you just mentioned the 1,000-pound gorillas. Wyoming is really nothing more than a small community. And are we able to make enough difference within the state that we can lead or maybe spur on the feds to try to do something? Or are we simply relatively helpless in this, that we don't have enough population or enough leverage?
Mr. Chairman, Representative Pendergraph, in relation to these ideas or to tort reform?
Mr. Chairman, thanks. Specifically in relation to tort reform itself. I'm just focusing on that. Can we, as a little community, make enough of a difference?
Mr. Chairman, Representative, I think each state kind of has to handle it on their own. And I think it's something that each state is wrestling with, and we have seen it take place in other states. And we've seen it considered in other states and get voted down. So I think it has to be kind of done. I don't think it's going to sway anything nationally. I don't think we'd be recognized as one that had passed tort reform, but I don't think that we're going to be a big impact on what's happening nationally.
Thank you, Mr. Boley. I also appreciate the reference to the prior authorization statutes that we've passed, the credentialing statute, the 2-year take-back statute. I think these were all passed over the last couple of years in our legislature. So the prior authorization statute allows for hospitals and providers to be gold carded after 5 prior authorizations. So once 5 prior authorizations go through in a year, they're gold carded for an entire year. So they don't have to submit a prior authorization ever again within that year period. So that's good work that we did. I would also echo the credentialing statute. That was something we talked about, where there's a big burden on the provider community to have to credential, go through that process. We worked really hard and got ideas from the Hospital Association on exactly how we could execute that statute and that legislation in a way that would be helpful to the hospitals. And then the 2-year take-back statute, basically, if there's an overpayment made by an insurance company, if that overpayment isn't recovered within 2 years, there's no ability for an insurance company to go back and take that. So those are all very good things. I would say as an insurance company, those do add administrative burden, costs associated with hiring employees to ensure that gold carding occurs. In addition to the credentialing statute, more staff on the insurance side to ensure that that process is taken care of in a timely manner, the timely manner that's required by the statute. So one of the things I think would be helpful is if we could work with the Hospital Association to determine the cost savings that have come through those 3 specific statutes that we passed and worked together on in order to reduce the administrative burden for hospitals and providers, right? So the cost was addressed, I think, through those administrative processes, through the passage of those bills. And I think it would be good if we could do a study or we could work together to determine how those bills have resulted in cost savings to providers and hospitals. Is that something that we could work together on?
Mr. Chairman, Mr. Ed, I would be happy to work on those things. I would say that it might be harder to quantify than we think because we're still dealing with the big insurance companies, but I do think it would be a good study to do. And I think the gold carding is a really important part of what was passed. And it would be great if we could get that done with the big insurers. And so basically gold carding is the provider shows this is how I would phrase it, shows expertise in the area, and they go through the process and they have very few or no denials over, and most of the gold carding for the bigger insurances is higher than what we set as a limit here in Wyoming. But then they don't have to do the prior authorization again because they've proven that they're good actors basically with the insurance companies. And I think that would be another area I'd like to see the big carriers, national carriers implement as well.
Mr. Chairman. Thank you, Mr. Boley. Blue Cross Blue Shield of Wyoming, as you know, got into Medicare Advantage this year. It's our first year. I don't know what the percentage of participating hospitals within your hospital association is in that program. I'm not sure if you do. But I would say that I think you made reference to United Healthcare in Medicare Advantage. I'm pretty sure this year they were only in 3 counties in the entire state of Wyoming. So, and then they're exiting the market next year. So they will not be in the state of Wyoming. So those prior authorization requirements that might come through Medicare Advantage, I'm not sure that all the hospitals participate in Medicare Advantage, and United Healthcare won't be here at all next year. So I think that's something that's significant. The other thing that I would mention, we looked at denial rates just based on these materials that we're talking about today. Blue Cross Blue Shield of Wyoming's average denial rate is about 5% for across all claims, and specific hospitals, 3%. And of that amount that's denied, a very large percentage of those denials are for duplicate billing or claim codes that were included in a bundled payment. So for instance, the NCCI, yeah.
I don't think he pointed to Blue Cross and Blue Shield as denying claims. He's just talking about industry.
Right. And I think I was just bringing up the denials, Mr. Chairman, and I apologize, I'll stop, but they're in the presentation as a driver for cost. And I just wanted to make that comment. So thank you, Mr. Chairman.
Let's move. So before let's put this to bed on this portion of your presentation. So is there any one thing in this work that the Hospital Association has collectively worked nationally with that we could implement in the state that doesn't require federal action that you're recommending to us?
Mr. Chairman, not at this time. I think we've worked on the ones that we can.
Okay. So let's go on over and if you would make your introductions to our folks from Ready, and we're excited to hear their presentation to help us really better understand hospital costs.
Sure, Mr. Chairman. So over the last several years, our hospitals have been working with Ready Health. Ready Health is a data analytics company, started in Utah, and they can tell you their background, anything that you want to know. But they came to us, and the Office of Rural Health had some grant funding that we were able to leverage to bring Ready in, take a look at operations within our critical access hospitals. And as you guys are hopefully well aware, we have some of our critical access hospitals have been in pretty dire straits when it comes to their financial health and viability. Spent last couple of years, hundreds of hours, making sure that Memorial Hospital of Carbon County stayed in operations, and we've seen a good turnaround there. They've still got a ways to go, but they're doing great things. We've had a couple of other hospitals that we had to work closely with this last session, up in Newcastle. Weston County was on the verge of having their district dissolved. They had to do more with reporting requirements, but as we take a look at it, revenue cycle is the lifeblood of our hospitals, and it's what keeps them solvent and afloat and gives them the cash that they need to operate. So we had Ready come in, we contracted with Ready to come in and take a look at how they could help by doing analytics, and then also making recommendations on how performances could be improved in those hospitals. And so as we start talking about this affordability, as we start talking about pricing and expenses and cost, Chairman Larson and I have had a couple of conversations with John and with Jeff here, and thought that this might be some really good information to share with this committee to understand a little bit more about where pricing comes from, how that plays into the whole grand scheme of things, and where hospitals sometimes get into trouble, and maybe what we can do also on the flip side to be better at what we're doing. So if you guys want to introduce yourselves, and then we'll turn you.
Please, if you would, please introduce yourselves, and then whichever one wants to start off, that'd be great.
Chairman, thank you. I'm Jeff Grandia from Ready Health. I'm the CEO, and John Wadsworth here is the president. And I'd probably ask a lot of questions of why you care about us and what we're doing here, and especially after somebody like Franz presenting. You got some incredible people in Wyoming that we're super impressed with. But let me share a little bit about Ready and our history so that you can get a little context. And our goal here is to really answer as many questions as we can about financial sustainability in a rural hospital. But John and I have a background. Basically, around data and analytics, around financial and clinical quality improvement for literally between the two of us over 50 years. Our background is really with big health systems. So you think of the Intermountain Healthcares, you think of Stanford, Partners Healthcare in Boston, Kaiser Permanente. This was kind of how we grew up. And we spent a lot of years in those very big systems and helping them rationalize their data to really improve clinical quality and financial performance. And I think there's some phenomenally documented outcomes in our history. But 6 years ago, John had this crazy idea that let's do this in a very different market segment. There's this underserved market segment of rural healthcare. And to go help out these rural communities to help build financial sustainability and survivability. And with the methodology that has been kind of perfected in urban healthcare, big system healthcare, we thought we can port this to rural really easily, and it's going to be really successful and really fast. And we learned very quickly that the care in rural communities is actually very different than urban care. When you think about a hospital in a rural community, the impacts of a hospital aren't just providing care. Probably they're the largest economic engine or one of the largest economic engines in the community. Probably the people that are working in the hospital are directly tied to the community and have community involvement. Their families are part of the school. So it's a different environment. And so when we walked in 6 years ago, we thought, hey, we can port this new methodology and approach, and we have all these outcomes. It's going to be super fast and super successful. And we learned that there's a different dynamic. And then when you start thinking about the impacts of volume, you start thinking about the impacts of resources, kind of changes all of that dynamic. But what we've kind of seen through this experience is that data is really not that transparent in rural healthcare. The differences between how the providers in the system, the payers, the community really don't have transparency. Yes, sir.
So did you just a clarifier, please, as you refer often to rural healthcare, is there any hospital in Wyoming that wouldn't qualify as rural healthcare?
Actually, yes.
Okay, and who would those be? And how help us know who you're talking about then as you refer to rural health?
Awesome. So the federal designation of rural healthcare versus urban healthcare is pretty stark, but it gets a little grayer when you get into communities. So I think Chairman, you're asking a really good question, but essentially the hospitals in Cheyenne and in Laramie would be considered urban healthcare, and pretty much, what's that? Oh, and Casper would be considered urban healthcare.
Is there a designation at Frontier as well?
You want to answer that question?
Yes. This on? Thank you. Commissioner, we are operating from the federal designations that have already been alluded to. So a critical access hospital, that is a federal designation with some terms, certain distance from urban care, rural health clinics, those have also been brought up, and federally qualified health centers. So for our purposes, unless we need to be very specific, we are generically lumping those RHC, FQHC, and critical access hospitals to our portion of the conversation.
And specifically to kind of the last couple of comments, and we'll get into the meat of the presentation, at least to open the conversation. But Ready, the way we work, we actually work across states from Maine all the way to Oregon. Our largest facility is Unity Health in Searcy, Arkansas, which is a 245-bed hospital. And our smallest is Grover C. Dills in Caliente, Nevada, which is a 3-bed hospital. And so you think about that dynamic. Oh, really?
Yeah.
And the dynamics of those are very different, but they have some common issues in their communities. And just wanted to give that context of kind of who we are and how we see the lens and where we come from. But the biggest thing I hope you see is the data that drives all the commentary. And we hope you'll ask questions about the data because you'll see different perspectives of data. But we're going to try to be as transparent as we can in the process.
We thought some visuals might be helpful as we describe some of what we've learned in working within 7 of the critical access facilities. By way of background, what Eric Boley had mentioned with some of the dollars that came through flex funding from the Office of Rural Health, that largely was to focus on a concept called Charge Master and understanding. We'll talk about what that is and what that isn't. And then some work that has continued independently of those funds. And that's important as we think about the sustainability. What happens with RHTP on year 6, day 1? Are there processes that I think Representative Geringer and Pendergraph have both asked specifically, are there competencies, are there processes that can be put in place in leveraging those type of RHTP funds that allow sustainability to move forward? So we hope over these next 7 or 8 slides as visuals that you will see examples of some of the exposure we've had to critical access hospitals specifically within your state, okay? We're gonna swap laptops here. Please indulge me for just a minute. I want to just give a little bit of a background because we hope in the Q&A that you will not pull any punches. There is some credibility, I think, behind what we're sharing today. For the last 30 years, it has been my privilege and a stewardship to work with healthcare data to improve clinical care, operational improvement, and financial improvement. For 24 of those years, it was with very large systems. The last 6, as Jeff has mentioned, has been 100% focused within rural systems. That work has changed the way that we think about healthcare. In a rural community, a hospital is much more than a business. It's an employer. It's an economic anchor, and it's often the only practical source of care available for a community for miles. The people who choose to work in these facilities, FQ, RHC, or hospitals, are there by choice, and they're struggling to remain financially viable. We are not here to defend hospitals nor to criticize payers. I want to make that very clear. We have found problems and opportunities on both sides, and we're here to share what the data have taught us, where unnecessary cost is entering the systems, and where money may be lost between care and payment, and where better information can help Wyoming, particularly committees like this, protect both affordability and access to care. That advance, there we go. One of the most important points that we want to share today is that we agree with some of the comments that have been made, but also documents that have been produced. Payers have said this very clearly. Most of the premium dollar goes to pay for care. Blue Cross Blue Shield of Wyoming has reported about 93% of its 2025 premium revenue was spent on healthcare services for members. And that matters because if we're serious about making insurance more affordable, we need to understand what's happening inside that medical cost. But there's a caution here. We want to make sure that we're not treating medical cost as one big number. There are different things inside that number, and we hope to break some of that down for this committee today. Some of that is care that we absolutely want people to receive: an emergency visit, a mammogram, a surgery, treatment for cancer or chronic condition, or keeping care in an emergency department open. Some of that may come from differences in what the hospitals pay for supplies, drugs, implants, and equipment. Some of that comes from the price that a hospital with an insurance company have negotiated for a given service. And some of it is simply friction within the system itself. A claim that's denied because information's missing. A test that was not authorized correctly, or a coding error. Staff at a hospital and the health plan are spending hours going back and forth, as Mr. Rudd has mentioned, those administrative costs. And they should not have the same solution as we think about these different problems. If the problem is the price of an implant, purchasing may be the answer. If the problem is an avoidable denial, then better documentation, transparency and better payer providing workflows may be the answer. If the problem is a negotiated price, then transparency and competition need to be part of the answer. If the service is essential in keeping care available in a rural community, then simply cutting payment may create a different set of problems. So our message is simple on this particular slide, that the goal should not be to cut access to care, but rather identify and remove avoidable costs while protecting the care that Wyoming families actually need. And to do that well, we have to be able to see what's inside that 93% number, not just the total number at the end. I want to direct your attention here to the screen. What we're showing here is from that previous slide, understanding what sits inside the medical cost. This slide is about understanding the comment that Eric Boley made, and that is the lifeblood of whether you're in a hospital, RHC, or an FQHC, is that revenue integrity process. These are some of those basic steps that need to come through. This is how a healthcare dollar actually moves through the system. The process starts with something very simple. A patient receives care. But from there, a lot needs to happen correctly. The care has to be documented. The right codes need to be assigned. The right charge has to be created. The claim has to be built correctly and then sent appropriately and timely to the health plan. The payer then reviews that claim and decides whether or not to pay it, or deny it, or ask for more information to clarify. That is a long chain. You heard that in a personal testimony here from Eric just a few moments ago. And every step indicates an opportunity where something can go wrong. A physician may not document enough detail in the clinical notes. A code actually may be wrong. A charge may be missing. Prior authorization may not match the service that was actually performed. A payer rule may not be clear, or a claim may be denied, or a payment may not match the actual contract with the payer. And when that happens, the cost doesn't disappear. Someone at the hospital has to investigate it. Again, Eric's comments about 3 nurses sitting at the front desk, you're taking care provisioners in a nursing shortage to chase an administrative burden. Similarly, as Mr. Rudd mentioned, someone on the payer side needs to chase that down as well. So payment then gets delayed. People spend more time fixing that episode of care. So this is why we think Wyoming should consider looking at the whole path of the dollar, not just as one number. This is where we want to be very careful that we're not turning this conversation into payers versus providers. Hospitals or clinics control some part of this process. Payers control other parts. And there are several places like prior authorization, eligibility, appeals, and data exchange where both sides do affect the outcome. So the question we try and answer with the services we provide from Ready are, where did the dollar get stuck? Why did it get stuck? And what can we do to change so that it moves correctly the next time? If Wyoming can see that clearly, then the state can begin separating necessary healthcare cost from avoidable administrative cost and start solving the right problems with the right tools. Let's spend just a little more time on one part of that chain, okay? This has received a lot of attention in some of our previous conversations, and it's come up again today. Charge master. First, what is charge master? A charge master simply is the hospital's master catalog of services, procedures, supplies, and other items that it can and plans to bill. It helps translate what was actually done clinically into ultimately what becomes a bill. Each item has information attached to it, including what the service is, how it's coded, and how the hospital's listed charge is represented. So that's what it is. Let's talk about what it is not. It is not the hospital's true cost. This is really key to understand. It does not reflect the true cost to provide that service. It's not necessarily what the insurance company will pay. And for most insured
So,
yes,
so explain just a little bit further when you say it's not their true costs. Is it,
let's say if a hospital lists a charge of $1,000 for a given procedure, and that procedure is done in the hospital. And the contract for this insured patient says we will pay 60% of that charge. You may have a list price of $1,000, but you have a contract that dictates the terms of that. For this procedure and that patient, we will pay $600. So if the hospital is billing that at $1,000 and you have a contract for $600, then you actually have a delta for what is actually paid. Does that make sense?
it does. Is it similar if we were buying a car on the list price versus?
You could think of that loosely as an MSRP and a discount. But what this doesn't yet represent is what is actually going to fall to the patient in terms of premiums. And I don't want to lose sight of that, because everything that precipitated this conversation is our premiums are rising at an unsustainable rate for the Wyoming families. And so we're trying to help this committee and others, especially in the hospitals and clinics, understand the importance of the charge master done right. It's less about how much can I charge in setting my rates, and more about, is it complete and accurate for the reflection of the complexity of the care delivered?
Agreed, and well said. But I think various articles that have come out this last year would suggest that there's really not clarity in what the charge master catalog is based on. And when you've seen high reimbursement rates, or the negotiation between hospitals and insurance companies this last year are reportedly to be higher than they've been in a number of years, and it's based on these charge master adjustments. And I think that the question then, similar to the automobile, what are those based on? It seems like in the world that most of us live in, you base it on something that you can get your hands around and say, because my price for A, B, and C is X, and I need to, in my charge master, be what it is. So if you, as you go through your presentation, just help us understand, maybe if you can, how those charge master rates are determined. But I think what I'm hearing you say is that's part of your job, is to help hospitals use an approach to the charge master catalog that is defensible. And defensible is just my term. I'm not trying to apply or accuse anything, but I think in this, it was based on some data that supports it. I understand, is that somewhat correct, that maybe those charge master exercises are not as scientific as we would hope they would be?
Thank you for the question. Yes.
One thing to understand, so the establishment of the charge master is a little more complex, and you're bringing up something important there. But the changes to a charge master year to year continued, and many of the hospitals here in Wyoming have had charge masters in place for a very long time. But they're also very restricted on how much they can change those on a year-to-year basis. So their contracts prevent them, and I think I want to make sure that we don't confuse the issue that
Who restricts them?
the contracts that they have with their payers.
Okay, so that would be the insurance.
Well, across the board, but yeah, I mean,
But it's not,
Cross Blue Shield, I would assume, would have the maximum of a 4% increase a year in their increases, and probably 2 to 3%.
No, that's helpful. I just want to make sure that it's not there's no federal regulation or anything governing on what they can do. It's just the agreement with the payers.
Well, there's certainly a federal influence in that because of Medicare and Medicaid pricing. But at the same time, as far as the contractual requirements are done pretty much on the commercial payer side.
Thank you, Mr. Chairman. And one of the questions I have, I guess, is how does the charge master distinguish between, say, an institutional payer and a self-payer? We hear about the rates being different for each one. And so I'm trying to wrap my head around that whole concept of why it's so much more for an insurance bill versus a self-payer.
Mr. Chairman,
Yes.
Representative Geringer, this is going back to my 20 years at the hospital in Kimmer. So the amount that we bill in the first bill is usually the same amount. What happens though is we have practices and procedures in place to help the uninsured, the underinsured. And so we have like a sliding fee schedule. And so based on their annual income, if they can produce documents to prove their income, there are discounts that are allowed based on those. So and if someone comes in and tells us ahead of time, hey, I'm uninsured, and they try to negotiate with them, we have protocol and procedures in place to help negotiate that with them so that it's manageable. Or we put them on payment plans. Most of them are interest-free to help them pay over time. And so the charge master, the price itself, it doesn't vary, but how it's paid does vary, if that makes sense.
Thank you, Mr. Chairman. I heard some hospitals have had the same charge master for years. And I heard about contracts with kind of a built-in elevator, like maybe no more than a 4% increase. How then does that work when we have technology moving rapidly and we have maybe a revolutionary new testing method or a treatment or something entirely new? How do we then go in and adjust the contract, the charge master, to absorb that?
You want it or?
And love the question. And I think we're actually going to address that in this next slide. If I haven't, will you do a follow-up on that? Because that's a perfect tee up. Most of our background in our career was with large systems. And I want to be very careful that what I'm about to say does not come off as a criticism, but more a reflection of reality of the difficult circumstances of rural administration for cause, for RHCs and FQs, because it gets to the heart of your question. We are shocked at common practices of adjustments that are made typically to a charge master. More often than not, it is, oh, it's that time of year. I need to go and review our charge master. CEO and CFO sit down with department leads and say, can you do your best guess on what you think we should make the adjustments to be? More often than not, it's not data driven. It is a gut feel and make your best guess, and someone remembering how much can we adjust based on what we know or don't know about our contracts. That was shocking. Having technologies where we can map, I'll get right there, having technology that can help us with the mapping. This next slide actually illustrates that kind of complexity that they're trying to deal with. Commissioner, please.
But then is it fair to say that lack of data is detrimental to both sides?
Both sides, absolutely detrimental to both sides. And you see that reflected in a lot more of the denials because you have incomplete codes. CMS is constantly pushing out new codes, new adjustments. And if we're not adopting those, you submit a claim, it has incomplete or erroneous codes, it's immediately denied. And now you've created administrative burden on both sides. Yes. So this is where Charge Master gets really interesting and becomes much more practical for premiums in our discussion today. When we work with hospitals to review a Charge Master, the goal is to ensure that the billing record accurately reflects the care that was actually delivered. I want to repeat that. The goal is to ensure that the billing record accurately reflects the care that was actually delivered. So the driver on this is the complexity, the holistic view of how complex was this encounter, this patient? What does the surrounding level of acuity need to deliver that care? Then you back into, are the charges appropriate? And that matters because not every patient requires the same level of care. A simple visit is different from a complex emergency visit. A minor wound is much different than a deep repair that requires more staff, supplies, clinical judgment, and hospital resources. At Crook County, for example, we reviewed more than 4,600 active charge items. We found outdated codes. We found modifier issues, duplicate items, and places where the billing structure did not fully match the care delivered. A clear example popped to the top of this analysis: wound repair. The analysis identified that the facility component of the wound repair services were not reflecting correctly the complexity of that care. And so if a patient requires more complex level of care, the coding and charge structure should reflect that complexity accurately and consistently. And this is important both for the payer and the provider, as Commissioner Larson mentioned. So a payer should actually receive a claim that clearly shows what the care was, how complex the care was, and that makes the claim much easier for review. We also look for the opposite problem: charges with unusually high codes that are outdated or billing structures that just don't make sense. So the goal of the charge master is better clinical and financial alignment. The care delivered, the documentation, the coding, and the claim should all tell the same story. I want to pause here. When we got to the end of these 4,600 codes and reviewing, I know there have been some publications saying there's this arms race that's escalating between payers and providers, payer and provider, and without good data, we just keep escalating. We showed in that analysis and working with Crook County, they wanted to actually consider the needs of their community. Their overall rate that they chose to implement was 1%. That's not even the cost of inflation. But this is recognizing where the consumption of care, the need, translates into how do we take care of the needs of our community. Without good data, they can't do that. It's a thumb in the wind. Representative Pendergraft, was there a follow-up? And then Commissioner.
Thank you. I didn't really have a
I'm sorry.
follow-up.
I don't know protocols. I'm all over the board here. I
Lloyd.
apologize, Commissioner.
Lloyd.
I was getting the impression from what I was hearing earlier that these charge masters tend to be a rather rigid, fixed, long lasting. I have a poster in my bathroom that talks about hospital charges. You know, if you have, are they that old? But, you know, you compare that with technology and you may have 6 months from now, an entire line of treatment might be completely obsolete because we figured something out. So how are those reviewed? How often is that done? It must be an ongoing process of sorts. I'm just trying to wrap my head around it.
Commissioner and Representative, there is a need not only to review those annually, but a maintenance component to that as new charges do come out, or a new service line is spun up within a hospital, or an expansion of those services that the charges actually are reflected in that. So there's a maintenance component that should come in. Technology can definitely assist with that.
While at each time those adjustments are made or reviews are made, the charges have to be based, the charge master charges should then be based on data-driven charges.
Yes.
Which I think you alluded to earlier, that you can't just sit the doctors down and say, We got to get this out tomorrow. What's your best estimate?
Yes.
It's a big data-driven process. It's a bigger process that we employ in that and others in the mix. Recognizing in every case in Wyoming, we recommended in facilities that some charges go down. We recommended that some charges go down in every single facility, and we recommended that some charges go up based on those data-driven kind of thought processes.
So how do we help hospitals? Or maybe that's your job, but how do you then help hospitals appropriately assign charges to their charge master? How do you get correct? Yeah, you get hire Walmart. Is there a process that helps hospitals generate a data-driven charge master?
The approach that we have taken, and I'm not saying this is the best approach, I want to be transparent about the approach that we've taken, is by virtue of the access to publicly available data through things called SAF files, we can show comparatives with at least 5 similar size institutions as a rough benchmark. You also have benchmarks against what percent of Medicare for a given procedure as a baseline for the beginning of that. And then ultimately, what are your current contracts in payer negotiations? So all 3 of those largely come together to inform. We step back and say, ultimately, that decision is yours for you, looking at the needs of the community and the relationship that you have with your payers.
So if you look at Medicare and probably using the ARPA payment limit is the basis, and that's kind of formulated across the nation on what they allow, all things considered, there's a real basis there on how those are, how they come about as you compare to other hospitals in the area, reasonable size. How confident are you that their charge master process is appropriate to use for comparison?
Excellent question. It's the reason is it is one variable in there, because we may not have the detail on those 5 comparisons to look down specifically. Have they set those at the right rates? But it does let you have at least a benchmark compare. But that is not a perfect process. Sure, you're right.
Madam Chairman.
Thank you, Mr. Chairman. Appreciate what you do. Excellent what you do. I hope all of our hospitals utilize your services and research. As policymakers here who make laws statewide, help me understand how we can use this to create policy either through information presentation here today, in that there may be evidence to indicate, and I know nobody wants to say this, but there may be evidence to indicate that our hospitals are charging too much and too less for certain items, and that needs to be readjusted. But how do I turn that into policy to understand how to reduce these costs? So help me get there faster. I get it. I get what you're doing. Your operational efficiency for the company. Place this technology into any company, and how do we make the bottom line more efficient? How do I turn that into policy? How do I turn that into a law?
Okay. I think all 3 of us probably have an answer here.
Go ahead.
First, cutting to the chase. We need full transparency in chasing the dollar. Charge master is part of this. We have to look at the denials. We also have to look into cost. We haven't even talked about cost yet in here. How do you get to the actual cost of what it takes to provide that care? That cost needs to take into account consumption of the care for the community. Is the goal to turn every rural town into a tertiary quaternary center in the state? Absolutely not. You don't have the volume to justify it. But we don't have the data yet integrated to show what is the cost of keeping mammography in Basin, Wyoming. So to turn that into policy, we need to integrate cost, the payer, the charges, and the consumption of that care, so you can advocate for Is there a 1332 waiver that would make sense here in subsidizing? And do you want to regionalize or do you want group purchasing? That's where I think we can get the transparency to serve back to better policy.
Thank you, Mr. Chairman. What data don't you have that you need?
Access to all payer claims data would be a key component. And hospitals having the time to understand if they will open their doors in the data, not just to tie hospital data, but we've already alluded to FQHCs are a safety net for your communities, and RHCs are either attached to or feed into those hospitals. If we're serious about primary care succeeding and moving upstream, we have policy today in terms of reimbursement that is disincentivizing actual value-based care. What I mean by that is when a RHC is reimbursed on an all-inclusive rate, and they are potentially the first point of contact to identify diabetes or a rare chronic condition, and we are finding diabetes show up for the first time in an ER, clinically, that is a train wreck. That is the most costly form of care. Integrating what is happening from RHC to FQHC and hospital lets us look at a regional level care need and consumption or rising cost of clinical condition. Marrying that up with all payer claims lets us then position which service lines make sense to regionalize and which ones do you not need. It drives greater cooperation. That also positions you to drive direct contracting with the large employers in the area to say, if we are going to remove certain costly procedures from the hospital because the site of care is so much higher, and we can do that effectively in an outpatient setting, we have created a vacuum of financial services they depend on today, but the right thing to do clinically is move that upstream. How then, and I'm going way beyond what you asked, but this is the vision here. How then do I replace access to higher acuity services? Our answer in part would be contracting with tertiary centers to use telehealth, better technology, raise the acuity competency to put new or expanded services as a replacement for those dollars we're moving now into clinics and our HCs. That way you are not shooting your hospitals in the head financially so that you can have true pop health in the primary care clinics. Does that make sense?
Yeah, right. I mean, yes.
Did that answer your question? Is there?
Yes, if healthcare truly were a business that was authentic in the free market, I think that would be correct. So let's start back to the original problem, which is access to all payer claim data. Why don't you have that?
We are not engaged at the right level within the state to have those conversations. As a small business, Ready Health, I'm speaking for us. I am not suggesting that the state is not willing to share that.
Who has the data?
I don't know who owns that within
No,
the state.
so we,
It's not the state.
Madam Chairman, we had, you'll recall, I think around 2017, when we done the all claims data payer database, we couldn't, and I'm looking for help here, but we couldn't require the private hospitals to provide that, or was it the employers? But the main sources of data came from the state, who was the largest provider, and then some of the districts, maybe. And look who's coming up. Look who's coming up. Can you answer that for us?
Sure, Mr. Chairman. I don't have a lot of information. That was a little bit before my involvement, other than, forgive me, HCMS. I know that at the time that was happening, I was the person extracting that information to then provide to that all database, all claims information. So I just know it occurred, but I don't have a lot more detail than that.
Bronze?
Mr. Chairman, yeah, it was an effort that started back in 2016 with the Wyoming Business Coalition on Health. It was not ever an all payer claims database. It was a multi-payer claims database that really focused only on the state employee insurance plan, a handful of other employers in Wyoming, and then there was some in Montana. And it was sort of, would extract, there was an analyst at EGI who would provide files to this Montana outfit, and they would provide this data. And we had a brief dashboard, but it was by no means complete. Certainly didn't have, it was not required to provide this data from any payer. I think the state could only really mandate, and I'm confused on my ERISA law, whether or not the state has the ability to mandate employers to contribute this data, but I know as a force of law really only can regulate private insurers. So if this were to be a mandate, I know you could require Mr. Red's organization to provide that data, but at the end of the day, there's lots of employers, 51% of the lives in the state are under employer plans, and those are regulated by the federal government, Department of Labor, and preempted, that preempts any state legislation on that. But I know there was a Gobey versus, there was some court case back in the mid 2000s about this in Vermont, and I'm not 100% sure legally on how that stands. Nonetheless, it was a very small amount of data that was in this database, and it's short-lived.
So to make myself clear, then the provider of the information is the insurance company. Is that who that would be? And so when you talk about employers who have health insurance plan, do the employers have to give permission to the insurance companies to, or what? Where's that bottleneck that the insurance companies can't provide it, other than maybe it's something, it's an administrative burden, but.
Mr. Chairman, there's two main obstacles legally. The state really only has purview over privately insured or private insurance companies. So the state cannot generally regulate employer plans. That's a federal preemption issue.
He's talking about private employer plans. If I create my own plan because I have ABC Corp, I can create my own plan. We're not worried about that.
And then I think secondly, as a practical matter, there are so many small employers, and they may have a third-party administrator. It administratively would be difficult to collect all that data just based on the sheer diversity of employers out. If you truly wanted an all-payer claims database, that's a very tough thing to achieve.
Okay, I could go, we need to talk more, because that really is an important component as we draft policy on what costs are. We learned that for the brief time we'd done the multi-payer claims data back then. It was very revealing on charges across. And so if you look on some of our information that I can't remember if you provides or Rocky provide or Dirk provides, that shows some reference back to 2017 on really extreme costs above the Medicaid rates, was extrapolated, I think, from that information.
Mr. Chairman, that's correct. The organization gave a lot of that claims data to, I think it was, I forget the organization who did it, but they included our data with a bunch of other national all-payer or multi-payer data to look at how bundles of care. So like, what is the cost for a delivery when you include the facility fee, the physician fees, and all the surrounding bills that get lumped into that bundle, and they would compare the cost that the payer, that the insurance company and the member actually paid. They compared it to reference levels on nationally, and we were significantly higher than the national average.
Okay, we'll need to, sorry, we got off in the weeds, but I think it's an important point that.
There's not complete data, so.
Yeah.
What is the point?
Yeah. But before, and I'll go to Rocky. Anna, would you just make a note of the all claims stuff that we need, I would like to investigate a little bit. Mr. Red, please.
Thank you, Mr. Chairman. The transparency files that the transparency federal statutes require for health insurance companies, I think, contain a lot of the data that you're talking about. Now, the data is thick, and there's a lot to go through when you're searching through those files, but I think maybe what we're talking about here is the state assisting with bringing all that data together in like a manageable way, because it does exist. I mean, it's out there. It's already available. With the hospitals, there's, I think, only 100 shoppable services that their data provides. So it's limited with what the hospitals provide, but with insurance companies, we provide all the data through the transparency file. So I think what we're talking about here is providing maybe an easier way for hospitals in Wyoming to use that data because it's already available. The other thing I would say is that, with the charge masters, maybe this is just a good segue to get into discussing, a revenue cycle management program for hospitals. And I totally understand that. If we're talking about reducing health insurance premiums, for this specific instance on this slide, I'm not sure how receiving $220,000 extra dollars would result in a savings there, but I understand where you're coming from when you're talking about revenue cycle management, which is a little bit different than affordability. But I think the main thing that I wanted to say there was the charge master doesn't really talk about ICD-10 codes, or at least at Blue Cross Blue Shield of Wyoming, it wouldn't result in a denial if a charge master wasn't updated. I think Representative Pendergraft mentioned, we've had hospitals not update their charge masters for 10 years, and we're not denying claims based on ICD-10 codes or CPT codes or CPT codes or anything like that. So I'm not really sure what the impetus of that would be. And 85 to 90% of the hospitals that we reimburse in Wyoming are a discount off of charges. So I know there was a reference made there about that some, for us, it would be 85 to 90%. So if the charge master increase went up, then of course the amount that the hospital got paid would go up as well, right? Okay. Thank you.
Yeah, thank you. Please.
I think there are two additional points that we want to get to, and I apologize, we've run long. We want to be respectful on time, but there are two other areas, one specifically with denials and then really getting to access. Access to care. There's a poignant story I'd love to share out of Basin, Wyoming. So denials. Let's make sure that we're giving this enough time, but hopefully I don't step in it like I did in the last one, okay?
Oh, you're fine. This is good.
This is another area where unnecessary cost has entered the system as we track the dollar all the way through. A denial can sound simple. An insurance organization says, no, the claim does not get paid. But operationally, a denial creates work on both sides, which we've mentioned. Someone's got to chase that down. Why was this denied? What was the reason? I got to figure that out. And the same on the payer side. So even when the problem's eventually corrected, both organizations have now increased administrative overhead. This is why we focus so much on preventable denials. This is where technology can help as we educate hospitals. In one Wyoming assessment, we identified just over a 2-year period for Medicaid and Medicare, $746,000 of preventable denials. Why can we say that these are preventable? In a subsequent conversation, or even in slides, if you'd like, we can send you, with their permission, what the exchange comes back, because when a remittent file is sent, these are called 835, 837 files. When that comes back from a payer to a facility, they are saying, these are the reasons we're either asking for more information or we are denying. It is related to specific codes. Those codes are national codes. So there's no mystery in this. The complexity is the number of codes, the sheer volume, and the reasons that they may be denied, and then going back and going, how do I fix this within the medical record to justify the new code, the new bill? It's that minutia. But just between these two payers for this 11-bed facility of $750,000 essentially in preventable denials. So on top of the $750,000, you have this administrative burden. You've created that on both sides for the payer and the hospital. As we dug into this with the facility, we could see most of this was tied back to registration. And I had no idea Eric was going to share the story that he did, but it shows If we don't get things right at the start of that patient encounter, it cascades. And often that is manifest 4, 6, 9 months later, that you're still trying to resolve a bill, as he shared. So denials drive premiums up because fixing them requires an increased overhead for both. So our principle on this is if we can get the documentation right, get the coding right, make the payer rules more transparent for that revenue cycle team, that's not taking a shot at any payer. It's making clear these are the rules of engagement contractually you're obligated to follow. And when you don't follow that, then you get that denial. So pay it correctly the first time and done correctly over time, then those savings begin to accrue because you're avoiding those denials. Just want to pause and ask if there are questions on this before we move to the next slide.
Go ahead, please. Please.
The hospital that's identified here is a $15 million annual revenue hospital. And in 2025 had an operating loss of 1.2 million bucks. So when you realize what $750,000 of just a preventable denial means to that community, and totally understand a lot of the complexities, but the difference for the state and for that community in solving that issue. Just from a sustainability, that doesn't go back to the fundamental purpose of what this does to a resident or a family member, but from a sustainability of a hospital, just this one issue can take out a majority of the operating loss of that hospital. Okay.
Mr. Chairman.
Please.
Yeah, thank you. So, I mean, somebody should maybe lose a job for that, right? And so I'm just wondering how do I use this data to make broader policy to help reduce healthcare costs when the issue may be, the wrong people in the wrong positions in rural healthcare systems, i.e. there's too much going on for them to do the jobs well, that these types of mistakes are happening that could result in a $746,000 loss because they're not billing Medicare or Medicaid properly. Is that what I'm learning here? Is that what the assessment is?
Yes.
I know we don't want to blame anybody and everybody's doing a great job, but that's the assessment, is that the hospital failed to bill Medicare or Medicaid properly or put the right systems in place to do so, and resulting in a loss of $746,000 for their bottom line, in addition to maybe challenges to that patient's care for how that care was being provided. So how do I fix that, having identified that problem as a state policymaker, when it may be a local CEO or a board or CFO or something else? What's my solution here?
Your question is poignant. We see a high attrition rate in registrars. Are we getting the correct information at the right time at the start of that encounter, and in coding and billing? Those are two areas that we see consistent struggle for hospitals to recruit. And so you see strategies like outsourcing of coding and billing. We see technology is helping to advance and make that handshake between payer contracts and a revenue integrity process more and more available. What we don't see yet is the technical sophistication embedded within FQHCs, RHCs, and hospitals themselves to catch the technology. And I can't overstate the importance of that. That's why we're a services organization. We are not a technology company. These systems are oversubscribed to technology.
Yeah.
There's a gap in seeing how to leverage that. So your point is spot on. Someone should lose their job. They're already losing those jobs over and over and over. It's this treadmill. That didn't address the policy.
No, but Mr. Chairman, if I may, I mean, we're getting there with the policy, which is what type of resource could we provide at the state level that can be consolidated for all of these hospitals struggling for whatever their reason may be to prevent these types of failures from occurring? Would that be having more positions in the Department of Health? Would that be paying for statewide technology to help facilitate this review? And then a second question I have that's not necessarily towards the solution, but do these types of things get caught on an annual audit by external auditors that hopefully come in and do some of this?
Answering the second question first, I don't know. We do not work with auditors typically. I'd probably defer to Eric or others that may have some of that administrative experience. And then if you've got a comment, be happy to address the first.
Mr. Chairman, Chairman Nethercott, I would say sometimes. And I think we've identified a really important topic, and that is workforce and training in our state. And there's a lot of detail in these, and we're finding a trained coder, I don't even know if we have a class in the state that does that to help them get trained. There is a lot of outsourcing, which you could say probably increases cost, but it might save on the other side. But yeah, there's a tremendous amount of turnover, and the workforce itself is shrinking. So people do get in trouble for it. I trust you. Trust me. I would hope that most of it is caught during the audit process at the end of each year.
Mr. Chairman, follow up.
Please.
Does the association offer any of that training?
Mr. Chairman, Madam Chairman, we try to find resources. That's part of the reason that Eddie's here is we partnered with them to help start this process. I also believe that some of the GPOs that some of our larger hospitals have offer some of these resources. I think some of the systems that they're involved with through affiliate agreements may offer that as well. Those that are affiliated with Billings Clinic. I don't know the exact details of all those affiliate agreements, but I think the UC Health might provide some of those resources as well. But from a policy standpoint, I'm not sure the right answer here. It's a conundrum, honestly. Where does the state step in?
Yeah, right. So I mean, we've identified a problem, which is there's a failure of resource at the hospital level to properly bill, resulting in a loss of funds, resulting in probably harm to patient care. And so, the solution there could be, either help provide a technology resource to prevent this from occurring that, of course, no local hospital can afford. And but we could help consolidate that potentially and provide that resource to ensure that everybody's getting funding. Or, like the master vendor contract that's statewide for all of the hospitals to prevent this type of loss, because ultimately it just comes back to us anyway. Or some other type of oversight connected with training and create it more burdensome for everybody, because I know hospitals want more of that.
Mr. Chairman, more regs, that's good. Mr. Chairman, Madam Chairman, yeah, I think the other thing that we're lacking here, and maybe we're going to talk, but documentation, it's not just on the intake side of things. So documentation changes that are taking place for what providers have to put in their charts and helping with that. And I mean, there is always the human element in this where you're not going to be able to automate 100% of it. So we're not going to be able to eliminate 100%, but I do think there are improvements that could be made. But those are constant things that we're dealing with, as well as trying to get even more documentation from the provider to make sure it's coded properly. And the feds have changed the coding process. We went from we were talking about this earlier, 10,000 codes to 70,000 codes. And now we have to get specificity down to if it's a left thumb or a right thumb, or if it's a dog bite or an alligator bite or a snappy turtle bite. I mean, we've gotten to the point where we may be gathering almost too much data, but those actually exist in the coding. And how do you get a provider that wants to spend that amount of time when it's got another patient waiting in the emergency room?
So let me ask a question. You've got a few slides left, which this is important to us. I just need to kind of get an idea whether we should take a break and let you finish, or how long do you think you need to finish?
Commissioner, with all due respect, that depends on the number of questions.
Fair enough, but give me, this is the charge master. Give me your best guess.
10 minutes,
How much?
10 minutes.
Folks, you want to take a break or do you want to? Please continue.
Okay. Commissioner Nethercott, I'd love to give a potential solution. Training is important, leveraging the existing technologies, and perhaps something the state could consider is a small pilot that shows training could be replicated across 2 or 3 sites, integration and transparency of disparate data sets today, and focus very specifically on chronic conditions because we know those contribute most to the rising cost of care. Those would be areas that we would suggest potential pilot solutions, and this is not theory. I want to emphasize that training in my former roles with larger systems, I have worked with and trained over 300 analysts in my personal career. In my 6 years of working with rural, now across 19 states, legitimately I've met 1 data analyst. That is not a criticism. That is a failure of being able to translate what we know and have learned from big systems, and it has not yet gotten into rural. But these are learnable skills that we can teach these because we have done that before, and we are doing it in other rural systems, just not yet in Wyoming. Okay, this last point here, this is from Three Rivers with base in Wyoming. Behind every premium is a person or a family. Three Rivers gave us a great example. Their board was discussing why in the world do we do mammograms? This is at a board level, not a criticism of the board. It's a legitimate question. Why? Because the losses for that system had been so dire. They're looking at every stone, turning this over. So imagine basic care for women here in Wyoming and saying, why are we doing these services? We did a cost analysis for what it would take to justify keeping that open. They didn't even have a certified tech to do the mammograms. They had to contract for that. They didn't have the equipment. They had to lease it. What we found is to break even, you need 60 of those a month. We also found many insurance plans already have that as an available feature. We're not taking advantage of this partnership that exists in that. In order to get certified for the board decision to provide these, they needed a certain volume. They didn't have the current volume from patient awareness in the community to do those. So what did they do? They got creative. And as a hospital said, let's offer this free to every one of our female employees. And they found 12 with spots under the age of initial screening. I just want that to settle here. Those spots potentially could be a disaster by the time they are of age. And if they have the screening done, this is where the partnership with payers is so crucial. It's a benefit that was already paid for and just not available. And once that was an awareness for the community, then there became an active campaign to drive that outreach into the community, and they are well beyond 60 a month. This is a huge success for that community. I'm going to jump to the last slide here because I said we do this in 10 minutes. Where does this leave us? I think the most important conclusion is Wyoming does not just have one healthcare affordability problem. There are contributing problems to that overall problem. And they require different tools that need to come together to address those problems. Section 1332 waiver is one example. A reinsurance program can help lower those in premiums for an individual insurance market, helping those health plans manage the cost of very large claims. That can be valuable, but it's important that we understand what that does and doesn't do. A reinsurance can lower the premium that people pay, but it doesn't lower implant costs or prevent a denial or change the price of a hospital service or make a rural service line more important. Those do require different questions, and I appreciate Commissioner Nethercott's questions along those lines. So what do we do? After working with healthcare for 30 years, healthcare data really is complicated. These are difficult problems. But spending the last 6 years here focused exclusively on rural, we don't believe that these problems are beyond your abilities to understand and improve. We've learned that the complexity is manageable if we can break it down. Follow the care, follow the data, and follow the dollar. Find where the process is working and where it's breaking, and who is in the best position to fix it. This is work that is being done in other states, and we can give you the evidence of that. We appreciate the seriousness that this committee is taking to investigate this work and approaching it, and we'd be honored to help in piloting some of those solutions going forward. Thank you.
Mr. Chairman.
Thank you, Director Johansson.
Thank you, Mr. Chairman. Building off of Co-Chairman Nethercott's question earlier and using the example that was on one of the slides that you mentioned, an avoidable denial total in one setting of $746,000 at a hospital that operated at $1 million loss or over. Knowing that there's services like yours, revenue cycle consultants, coding, charge master consultants, et cetera, that can help identify, diagnose, and prevent that problem. Assuming you or another company is not charging $747,000 for that service, there presumably would be, a preference or an interest for that provider to say, hey, we could invest a little bit of money in this service and offset this, what translates to an operating loss. What's standing in the way of providers of the system of the industry doing that on their own without the need for a state subsidy to start a pilot, et cetera, to catalyze this and fund it? And why doesn't that occur? Because I think the pilot work that's going on with Ready Health in the state right now is funded by grant dollars from my agency. And so again, where's the implicit interest from the system? Is it a lack of administrative knowledge? Is it the attrition or turnover you talked about? And I'm sure the answer is it's a mixed bag, but that confuses me of why, what's the moral hazard of the state jumping in and saying, okay, we're going to figure out all of these issues that you have because you didn't bill appropriately, you don't have good revenue cycle, you don't code, your charge master is not updated, et cetera. Not to be too cynical, but why not let that administrative team fail? If it's that simple to overcome some of those issues, obviously not the entirety of the financial sustainability problem of rural hospitals, but in some cases can represent a significant chunk. Help me understand why that interest from leadership, et cetera, wouldn't be there to say, we've got to invest in this and fix these problems.
Answer. Yep.
You actually asked a very complex question, and you did. But it's the motivators of the industry, and that's the challenge. If you come back to the fundamentals of healthcare, and you have primarily nonprofit that don't have that financial system mindset of how do we maximize the return on investment in our business, and so they're trying to operate a business with I need to provide a service to a community, and then you have all the influencers. You just talked about vendors. You didn't even bring up payers, but I think you were referencing vendors. Why don't vendors come in here and fix this problem at a more efficient cost? It's a big win. Well, why? It's fundamentally when people are receiving care, when these communities want care, they don't want that. They don't want their experience outsourced. They don't want it. They want it to be taken care of in their community. And is there a motivation? And in urban care, it's easy to deal with those motivations. The volumes are so much greater, and access to the vendors, to the market are so close. I was in West Holt in Nebraska a couple of weeks ago. West Holt is 6 hours from nowhere. And we sat down with the CEO, and it was related to RHTP and some of the work that's going on in Nebraska with RHTP. And all of a sudden the CEO says, I just have to know, will I ever speak to you again once you get the contract? And it was a great conversation, but well, we already have the contract. It's not. But the reality is, from a vendor, what's the motivation of a vendor? It's no, I want to drop off my technology, handed you a tool, and then I'm I got to go to my next initiative. So does that local community get the adoption of the value? How much technology turnover is there in Wyoming? We kind of know the answer, and I think you know the answer. It's crazy how much money is invested in technology in Wyoming. And yet how much of it is really adopted? It goes back to the education and the experience of these teams at building processes. But who's the motivator to do that?
So but I want to kind of come back because I don't know that I heard a clear answer to Director Johansson's question. And Chairman Nethercott alluded to it, which is it the role of state government to oversee or to correct flaws within that system that they could correct themselves? And so, yeah, you can bill them out, but does that make sense as we sit here and we're saying, okay, what do we do? Long-term impacts to slow down the growth of medical costs, to reduce premiums. Do we get results of that if we step in and say, okay, you're not doing this correctly? Or do you let them fail and then pick up the pieces? So is it the role of, is there a role for government from what you've seen in a perspective, or do you leave them to address these concerns within a system that exists?
I do want to, Commissioner, if I may, address part of your question at least very directly. Our HTP has confused a lot of administrators. Our little business organically has grown over the 6 years, and it takes time for them to go through 2 or 3 improvement cycles before they get it. And that's an investment of time. That's an investment of some of their resource. And our first projects, if it's around a charge master in particular, we know we believe there is a lot of inefficiency, and we guarantee a 2-to-1 return so you're not increasing costs by just shifting from one to the other. But showing them you can actually fix what's broken in the workflow. We highlight in the data, here's what you're doing right 30% of the time. If we shrink the variation at the other 70% of the time, then you build that competency to fix it. That business has been growing until last year, and everything paused, and almost all of the administrators say, I'm waiting to see what I get, and then come talk to me. That's exactly the case here. We had started work specifically with South Lincoln without any money from the state, with Three Rivers without any money from the state. Both have come back and said, I'm waiting to see what I get from our HTP, and then let's advance. That is across the nation. So is it the role of government to let them fail or to intervene? You have a unique opportunity, a once-in-a-generation opportunity to provide funding for some pilots, but that is not addressing your question of do we let them fail or not. I believe there is interest in advancing growing capabilities, holding their coders, their registrars, even physicians accountable for complete coding, but show us the 30% of the time we're doing it right. Help us then fix the other 70%. The change management ability is almost non-existent within these systems. Not a criticism. It's a reflection of fire to fire to fire, how much they're putting out. But I will say, in our 30 years of doing this, never have I seen the advance and adoption of improvement quicker than in rural. Why? Because you have such limited resources within the hospitals. The same person that is doing registration is helping in other areas. She knows 2 or 3 steps upstream and downstream. And when you can show her data around that stewardship, she goes, I see how it works. And I know exactly why I need to change. But it's the education around the data for that stewardship. Same for the nurses, same for the physicians. The administrators are in a hold and wait pattern. The desire is there, and there's general confusion around, am I getting dollars or not? Outside of that, we have evidence of some systems that have said, I'm not waiting. I'm just going to pay for it anyway because we've documented the outcomes. And I need the sustainability. I'm not waiting for year 6, day 1. I've got to be building that now. We have both.
Thank you, Mr. Chairman. Obviously, this is not my field of expertise. I worked in nursing home for several years and watched. And what I saw and what I think I'm seeing here is a real disconnect between reality and paying for what happened. And that disconnect, I think, is caused by the idea that we can create a system, a one-size-fits-all system. If I apply that to my trade, which is cabinetry, you want a kitchen, we'll get a kitchen for $19.95. Oh, you want that too? Well, this is what a kitchen costs, so I got to do that. What I feel like we need to do is get out of the way more, allow the free market to begin to operate, because the way that the system is now, local innovation is crushed. What's the point in trying to develop a better way if this is the way it's done? So my question comes down to, what can we do that is the proper role of government to reduce this rigid idea that this is the way that it has to be done, and allow individual entities, hospitals, facilities, whatever they might be, to be able to get their billing more to a time and materials. This is what it cost us. This is what we did. It's going to be uncomfortable because we're going to lose control of things. But ultimately, I don't see another way out of it, because the more we try to apply one layer upon another layer, a common data system, we add that. Okay, now everybody's trying to fit within a mold that what works in Worland is never going to work in Chicago and vice versa. So is there some way in either of your minds? What are the first steps that we would take toward stepping back and allowing more of a free market in healthcare?
Chairman? So first of all, I'm worried about what you're reading in the bathroom. I usually have sporting like a hunting magazine, and they're not Charge Master on my wall, but other than that, so I don't see barriers to the free market right now. What I see is an unattractive market, and where the free market is working, I think an example is Gillette. So they've had that Hutchinson's, I think is like, yeah, that one, which is now, we've got Monument that just moved in from Rapid City that's leasing that building and is going to compete against Campbell County Health. One is a community funded and community owned facility. The other one is private. We don't have people knocking down our doors that want to pick up our critical access hospitals and enter the market. And so we have a system that has been built on a need in those communities, and the communities passed mill levies or did whatever they needed to show support for that. But the free market, there are no barriers right now. There's no certificate of need in place for hospitals. Nursing homes are gone now, but we don't see a flood. We don't see new nursing homes being built. We do see 3 new hospitals that have been built, which is pretty rare, especially in a state our size. The third one, I think, is supposed to be open in December, is what I heard last in Riverton. And it'll be interesting to see, because you'll have two competing different types of entities in that community. So you'll have 3 of them in Fremont County. So I don't think there are barriers to free market. I think this conversation about training and education and waiting for rural health, every one of our critical access hospitals but 3 received millions. And I think they've got the funding, if they want to use that, they have discretion on how that money is deployed. And we can definitely help promote that. I would also say, from an association perspective, we've been working with vendors just recently to provide more data and to provide discharge data, claims data, all kinds of things. We're working on it. So I don't know what the role of government is. I hesitate to put, I know, and I appreciate that, Chairman. I can hardly wait. I'm hesitant to recommend that the government gets involved in this.
So I think in light of time, we really do need to start moving on. We're about a half hour behind here. So, but if there's a question that is you still have, we want to make sure that you have an opportunity to ask them. If not, we'll go ahead and break, and thank you guys for your time. And we'll meet back here at about 10 after, please. We are back. Are we not? Thank you. We are back. Thank you. Great work. Healthcare statistics. These are some questions that we asked a little bit in the last meeting, and Libby has put this information together again to help us understand, so that as we address policy, that we can kind of have this tucked away in our minds. So Libby, if you'd please bring your white paper, and would you make sure that you're close to the mic, and we'll turn the time over to you. We may interrupt you as we go, okay? Thank you.
Mr. Chairman, members of the task force, my name is Libby Miles, Associate Research Analyst at the Legislative Service Office. As the good chairman alluded to, this was prepared prior to the first meeting in response to several questions posed by the chairman. It provides background information on healthcare in Wyoming, and the most recent year of data was utilized for each question. However, in some case that was 2020 or even 2017. So I will briefly go over the questions and answers and then stand for any questions. For question 1, regarding cost of healthcare in Wyoming compared to other states, in 2020, Wyoming ranked 36th in annual health expenditures per capita at $10,989 across all states. And for a more detailed breakdown of Wyoming's per member per month spending on commercial hospital care compared to surrounding states, please see Figure 1 on page 2. Moving on to question 2, regarding hospitals and hospital beds. In 2024, Wyoming had 29 community hospitals and 1,875 staffed hospital beds, representing 3.19 beds per 1,000 people. Wyoming ranked 8th among states with the highest bed to population ratio. For question 3, about the rate of uninsured individuals, in 2024, Wyoming ranked 8th in the rate of uninsured people with 9.7%. In response to question 4, regarding governmental employees, in 2024, the total number of people employed by a governmental entity in Wyoming was 67,646. And for a breakdown of the level of government, please see Figure 2 on the top of page 4. Moving on to question 5, on Medicaid expansion. In 2023, the Wyoming Department of Health estimated Medicaid expansion to increase enrollment by roughly 19,000. For question 6, about marketplace premiums, there's a brief explanation on the changes to the marketplace in response to both the introduction and subsequent sunset of the American Rescue Plan Act, of which there is an anticipated decrease of 8,000 to 11,000 enrollees in Wyoming. As of January 2026, the average premium after the application of premium tax credits was $235, a roughly 75% increase from that of 2025. In response to question 7, on profit information for Wyoming's health insurance company, Figure 4 on page 6 shows the net profit information by calendar year. And lastly, for question 8, the hospital operating margins were shared with the task force just prior to the June meeting dates. Additionally, the task force was provided with the Wyoming Department of Health Provider Financial Viability 2025 document, and that should be document number 18-1 in the packet. This was self-reported, publicly available data. And with that, Mr. Chairman, members of the task force, I stand for any questions.
Thanks, Libby. Appreciate your effort in getting that put together. Does anyone have any questions for Libby? Yeah, thank you. I do have one question on, and Franz, this might be a question to you on the financial health of Wyoming Health and Hospitals. Are you familiar with that document? And I was trying to understand what the, just going on to page 89 as an example, where it talks about top line Wyoming. What's the region? And what does that mean, or what does it relate to? And then I'll have a follow-up question after that.
Mr. Chairman, so this is table 243 in that document, page 89, and that shows we tried to calculate some common metrics of profitability and liquidity. bought for all the hospitals combined. And so obviously Wyoming, the hospitals in Wyoming, the region would be critical access hospitals in the surrounding states,
Okay,
excluding Wyoming.
okay, thank you. And then as you look at some of the critical, or some of the hospitals, you'll note consecutive years losses and net income with consecutive years net income losses, but yet they'll show cash on hand, even though it might be quite small. I'm just wondering how they do that. Do they not pay bills and keep cash, or?
Mr. Chairman, unfortunately, all this data here, and I hope you were clear in the report, comes from the hospital cost reports, which are reported to Medicare. And typically that which is relevant for Medicare payment tends to be the most accurate. So a lot of the financial reporting stuff is not necessarily audited by, account doesn't necessarily tie back to what they're reporting to Board of Trustees. It is most likely accurate. But for example, days cash on hand, there may be, for example, hospital systems where the mothership controls the cash. And so the actual hospital may report very low cash in the books. And it's just hard to know whether that's a true cash deficit or whether it's some arrangement with a system or some other parent entity.
Thank you, Mr. Boley.
Mr. Chairman, it could also be timing. I mean, they could get their mill levy payment at one point. Some of them keeping 3 or 4 days cash on hand is to make sure they can make payroll the next time. I think most of it's very fluid and very, very tenuous in a lot of those cases.
Okay. Any other questions? Okay, Ms. Miles, thank you. We're moving on to item 6, and this is our Wyoming Group Purchasing Organization. We have a draft bill to contemplate and review some things. So Anna, if you would kind of take us into that for consideration, please.
Thank you, Mr. Chairman.
Oh, there you are. Hi.
I'm here. Thank you, Mr. Chairman, members of the committee. I did have a discussion with you this morning, Chairman Larson. Basically, this bill draft, which is 27 LSO 78, Wyoming Medical Device Group Purchasing Division. This is one way that we could implement this model, which is basically the liquor division model that's used by the Department of Revenue. However, there's also, and under that model, then the Department of Health would be the sole purchaser, distributor, and seller of medical devices. There is another possible option that we could use instead, which would be basically to have the Department of Health enter into contracts to purchase medical devices at a contracted price and then buying those devices as needed. And I was asked this morning to maybe figure out what the task force's appetite was, either for the liquor division version versus just buying as needed and contracting for a certain price. And so I guess I would just ask if the task force would like me to continue to go through this bill or maybe prepare a different bill for the next meeting.
Thank you. Thank you, Anna. So folks, as you've read this bill, and we talked about the liquor division model last time, there's the idea that we would create this division so there's this administrative burden and expansion of maybe what the Department of Health or the division would do. And then they would buy all disposables and maybe apparatuses, knees being the common one we think of. We would warehouse them and then distribute them to the hospitals as needed. The concerns that I've heard and I think has value is, do then you try to warehouse all the knees manufactured, or do you then say this is the knee you will use? Do you what do you do when they become antiquated? Do you have a fire I just get this picture in my mind of having a fire sale on eyeballs or something, but on knees. And, you get 2 for 1. I don't know what you do there, but yeah, you get 2 for 1. I don't know. I got to get hold of myself here. So anyway, I think there's a Far Side cartoon there somewhere. But how is that implemented? And I see that maybe, at least in my mind, being complex. Then I think we have to assume that some of our hospitals, particularly our larger ones, are probably already participating in GPOs. And do we force them to leave that, or can we even force them to leave that? And so if our larger hospitals, who are going to be the larger consumers of these apparatuses, dilutes the value of doing that. So with that said, I think that there's some challenges, and I don't want to spend a lot of time on the bill unless you all feel that this is a bill worth pursuing. The other thing that we could consider is having agency always go to the Department of Health or A&I then that can negotiate like you do with motor pool on vehicles or repair items. Tires, a great example, and wherever they're at, they can go and get that discounted price. And so then maybe we have a bill that allows hospitals to opt into a GPO that then allows them to get that discounted price. And so first to you, Mr. Representative Pendergraft, and then just this, if there's support for the liquor model, and if so, then we'll continue on with this. So Ken, please.
Thank you, Mr. Chairman. I look at this and what's lacking to me is any kind of a fiscal note or relative size. How much money do we think we could possibly save by reducing that, as opposed to creating a division? You've got employees, you've got insurance and all the other things that go with that. You've got a building, perhaps, you've got a distribution system. That runs into extremely high costs in my mind to save how much? And without a relative idea, I don't think I can make a judgment other than no.
Yeah, Mr. Chairman.
Please.
Thank you. That's the proper criticism of the bill is how much will it save? We don't know that. The reason why we don't know that is we've had 2.5 days of working and the ability to do a meaningful fiscal note. We don't know. So I do think that's a question that needs to be asked. And so I think we could try to figure out that information and ask for a fiscal note and get that. To the question of whether or not we could force the hospitals to participate in a GPO type situation, the answer is absolutely yes, we can. In the same way that we can force every retailer in the state of Wyoming to only buy their liquor from us. Do I anticipate there ever to be this massive warehouse with 45 knees in it? No. I think it'll work just like the hospital storage unit works now, where they don't have large warehouses in their communities. They have stock rooms, no doubt, but they order on an as-needed basis. And that would, the same thing, the delivery truck arrives and it gets ordered. And so the same delivery trucks would arrive, but that contract would be through the state. And so it's just where that call goes in, but it's the same delivery services, right? It's going to be the same vendors with the same delivery trucks doing it, not the state of Wyoming creating a semi-truck fleet and buying warehouses throughout the state to store eyeballs and knees. It's the same people. It's just who that contract is with, how those savings come into place. And so in the same method and manner that the hospitals call for and they order knees, because I don't think they have a storage room full of knees. They may have 5, but if they need more, they have to call for more, right? And so that would go through the same place and just get delivered that way. So it's a consolidated master contract for all the hospitals. Do I think that's a good idea? I don't know. But I do think it's worthy of additional consideration when we hear that the cost of a knee in Cody is 12 times the cost of a knee in Cheyenne, which ultimately gets spread out across all of us for those different prices in knees when it comes to the cost of healthcare and insurance coverage and paying for those differences. So when we're trying to equalize the playing field across the state, hey, Laramie County, I got it good. My hospital's solvent. Can anyone else say that? Right, so we got it good here in Laramie County because we have an economy of scale due to our size and population. But when we're trying to equalize those costs, this is one way to do that. I don't know that I'd vote aye at this point, but I don't think it's something we should immediately knock out because we still need to talk about logistics and or fiscal impact.
Additional comments? Karen, let's go you, then Rocky.
Thank you, Mr. Chairman. I hate to be the cynic, but given the position of my position, the involvement with any kind of cost savings, I'm not equating it to buying a diamond, but you don't know what the markup is. And so unless there's some way to assure that, one product line isn't creating enough revenue for a hospital, this is where they're going to make it up. We're saving with the hospital's money. We're not necessarily saving on premium based on paid claims. So not sure how that would be handled.
Mr. Red?
Mr. Chairman, I would tend to agree that building something like the Liquor Association would be very difficult in creating warehouses. I think that the concept of it, though, kind of gets you to the idea that we're trying to solve for, which is that if we can find a way to measure and acquire these medical services, not services, but supplies at a better cost, then we should try to find a way to do that because of the differences that we see across, which is data that we will share today. I think the other thing is that if a hospital is able to do a better job than the state could do, then you should absolutely let them, use that opportunity as a voluntary, opportunity. So if the hospital is having a hard time acquiring those medical supplies, the state can facilitate that through this process. If the hospital gets it at a better discount, then absolutely you should be allowing that to happen. But I think the mechanism that's helpful is to know if that's happening, and then you can measure the reduction in the cost from there and be able to do what we're talking about here, which is reduce premiums because we're reducing the cost that it takes to acquire those medical services and the cost that it takes to supply those services.
Mr. Boley?
Mr. Chairman, since our last meeting, Kelsey and I've been working on this. And if it'd be all right, could I have her come up? We've studied similar programs, one that took place in Oregon. We've been in contact with a group that's interested in creating a GPO for our rural hospitals. We've been in contact with a company out of Laramie that offers even better pricing than some of our GPOs. We've talked with our members about their existing GPOs. I think one of the things to realize is that a GPO, if you've seen one GPO, you've seen one GPO. So some of our GPOs actually offer many other services when it comes to risk management, back office training, a lot of those resources that I'm not sure we could create in this. But I think we have maybe some good ideas on where we could keep the state out of this and still generate that bargaining power. One of the other things that we discussed as we put together, can she come up?
Sure. Kelsey, please join us.
One of the other things that we talked about during the Real Health Transformation application process is, and it's specifically listed in there, but we didn't list it the same in our application, but it's clinically integrated network. We went the route of chronic illness management, but the clinically integrated networks that are coming up all across the country are creating these pools where they have bargaining power both with manufacturers and others. And we're still considering potentially doing that, or it's called a high value network. It has two different names. So I don't know if it'd be all right, but Kelsey's just got some information she could share because she kind of sees this partnership side of our business right now with the WHA.
Kelsey, please.
Oh, there we go. Thank you, Chairman, members of the committee. Again, Kelsey with the Wyoming Hospital Association. So as the committee member mentioned, I do oversee this side of the business for the association right now. And we do have several concerns with the use of a state-run GPO, specifically because many of our larger hospital members are currently already utilizing effective GPOs that have experience and have been in the business for a really long time. They're able to tap into national contracts, regional contracts as well, to really aggregate the volume that they're purchasing. But in addition to just basic volume discounts, they also receive market data, market analytics. They can also receive pharmacy advisory services to see how they can save on drug costs. They also receive assistance in sometimes patient safety guidance and participation in patient safety organizations as well. So those are all items that if this bill were to be passed as written, or even substantially similar to how it's written right now, those are all services that would go away for our rural hospitals. And so that's a really big concern of ours. Something that the association is currently working on right now and that we have been for some time is exploring the use of a GPO that specifically works with critical access hospitals with experience in the field that's been doing it for a long time, and being able to tap in for our small hospitals that don't currently have access like our larger hospitals like CRMC or Ivinson might have. And so what we are exploring doing is utilizing a specific company that works with these hospitals to tap into those national contracts. And they're not tied to just one producer or manufacturer either. When these GPOs are being used, these group purchasing organizations, these group purchasing organizations have multiple different contracts. And so there's a lot of flexibility and there's a lot of competition maintained in the marketplace for those vendors and manufacturers to come to those group purchasing organizations, negotiate a contract, negotiate the best deal that can be reached given the rising cost of supplies, and then turn those over to our hospitals. In conjunction with that, as Eric mentioned, we are working with a partnership potentially with a facility in Laramie that produces, I forget what the correct terminology is for them, but actually the owner of the company is sitting in the back of the room today. But this facility manufactures different supplies like surgical trays or dressings and pins, plates. All of those materials are produced right here in Wyoming or with some of their partner companies that could be sold to our hospitals at 75% of the cost of what they're paying right now. So the key issue is trying to figure out how we partner a potential GPO, a potential clinically integrated network or high value network along with that facility to really drive down costs in Wyoming. And then what we would like to see is some collaboration with the insurance companies on how is that going to translate into lower premiums if we can work together as a group to figure out how those lower costs can really reduce out-of-pocket costs for consumers here in the state.
The question I have, Kelsey, then is two questions. How many of our hospitals in the state belong to a GPO? Then the follow-up would be, if they don't belong, why?
Thank you, Chairman. I don't have the number of hospitals that currently participate in a GPO. I do know that it is the majority. I would have to defer to Eric. I think he might know the answer to that question.
Mr. Chairman, most.
Please.
Most.
Yeah. So then the question.
And there's some flux in that, Mr. Chairman. So there have been changes, there have been consolidation in some of the GPOs. There are really only 2 or 3 big GPOs in the country. This group that's approached us to create the one for our critical access hospitals would actually be competition to them. We think by using that in conjunction with Mahi, we can really help lower their costs.
So then my question, Mr. Bully, would be, if most are doing that, why would you see such a cost difference between Cody and Cheyenne? Is it the actual cost of the knee or is it the cost of the procedure?
Mr. Chairman, I haven't seen any examples specific to that. It could be, I think we talked about it last time though. Orthopedic surgeons have preferences and you could buy a Stryker total knee, which might be $12,000. You could buy a Medacta, which they prefer $25,000. There's variance in what the providers like and their allegiance to the manufacturers. And so
Are they shareholders in the company?
I would hope not. I don't know, Madam Chairman.
The
But they
question
might have
was,
been
are the
wine and
shareholders in
dining
the company
it.
competition?
But so I don't know. I'd have to look at examples. I think we could probably pull the data and find out. There may be slight variations in the discounts that are larger systems in particular. And I would imagine that that through some of the affiliate agreements that they have, many have affiliate agreements with Billings Clinic, they might be able to access their GPO, which gives them more bargaining power. Our bigger hospitals that have UC Health affiliations, I think they have access and that gives them bargaining power, but some of our smaller ones may not have that. That's why we're kind of focused on that part of the market.
Well, in this, Madam Chairman, this really is the intent, is how do we reduce the cost of these apparatuses that then reduce the cost of the whole procedure?
Yeah, I mean, Mr. Chairman, I think the comment, just to pull one comment out of this whole piece and not to go off on a tangent is how the whole system is completely jacked. And there's no free market, right? That a surgeon is deciding the product that's going to go in my body because of his preference instead of the market or me who's paying for it or the system that's paying for it, but because he demands it, whether or not he has a financial interest in that company or not, or wants one because he intends to patent a product for that company, right? And so that should not be the driving factor. I mean, certainly as a professional, I want to have the best resources available to me to serve my clients. But that seems like an absurd result that there's a difference of potentially thousands or tens of thousands of dollars because a surgeon prefers to work with a certain provider as opposed to the product I want in my body, right? And so again, I think the whole healthcare system, from physicians to hospitals to everybody, the patient has been completely discarded. And I know no one wants to admit that, and those are fighting words, but it absolutely is, because the patient should be deciding the product in their body.
Mr. Chairman, the only thing I would say is there are a lot of different reasons that those providers may have preferences. They may have better outcomes with them. They may fit better. And sometimes there are big variances in the whole operation too, where maybe because someone's taller or shorter or whatever it might be. So there might be other reasons other than just that preference, but that it makes better sense for that particular patient. I wouldn't say that the patient's being disregarded in that. I think the providers hopefully are trying to do the very best that they can.
So, Madam Chairman, with the information, at least as I understand it, that most of our hospitals are currently participating in a GPO.
With no effective result.
So, Karen, please.
One of the things I wrote down as I was listening is, and Brocky, you may have the information. I'm sorry, I don't have it for state plan. What's the largest cost to insurance? Did we decide that it really was durable medical equipment? I mean, I realize hips and knees are made out of titanium and Lord knows what else, but a wheelchair, or is this really going to sufficiently move the needle, even if we could assure that if the cost savings happened, would the charge to the insurance or the contract still save money? Maybe it's cancer treatment. It's the preventable, both acute and chronic things by member engagement. I think that what's interesting is that I don't know what's the best hip. I'm going to take my doctor's recommendation. It's not my bailiwick, but there's so many facets to this issue. But one of the things that I know it's hard to get an ROI on wellness, but we're working really hard to try to change the tactic of health intelligence around how do I make my health decisions. Referring back earlier about the mammographies, I know several people who refuse to go get one. So they know full well that it's paid at 100%. They just refuse to go get one. So how do we engage the members and I realize I'm squirreling, but how do we get the members to do their part within that triangle of trying to move the needle on eliminating some of the things that can be prevented? But did we vet that DME, durable medical equipment, is really the thing that's going to change anything?
Mr. Red?
Thank you. Mr. Chairman, I would say durable medical equipment is one thing we're hitting on today. Hips and knees, I think, are easy to kind of go over because of the large variance in cost. It's a significant amount of cost, so you can kind of compare that to what the average is or the median is. But we're also going to present today on other supplies that could be, that where savings could be found. And I think the idea of doing something like this is to say, okay, we have a durable good. We have a good that we know comes from a location, and we can set a cost for that. And we already have to bring those goods and services into the state. The harder part, which we agree to, is that bringing providers into the state and the location of the hospitals and the remoteness of all of these things makes it difficult. But in something like this, we could track it, we could determine what the cost is, and we could really move the needle on that cost because we would know what it is and we could set a benchmark for that. And if a hospital can get a better cost, then they certainly don't need to participate and pay more. But they could benefit from that. But of course, we would want a mechanism that would set a tracking of the allowable cost that we're providing. So if we're paying $80,000 for a knee, should we be doing that? Should we be tracking that and saying, let's never pay $80,000 for a knee again? Because we've tracked it and we know that we can buy a knee for significantly less. And that goes towards a lot of different things, whether it's a gauze pad or an ibuprofen, you know, anything like that. Should we be paying $5 for an ibuprofen that you can buy for $5 for, you know, 2,000 ibuprofen? Probably not. So it goes across a lot of different places, but I think some of the more significant impact areas we can look at. And what I would say is that while GPOs exist, we're talking about like a cooperative here. We're talking about something that's voluntary. And if they can do better without it, then that makes complete sense. But if it helps, then they can certainly leverage it and use it just for one basic thing. And then we have a benchmark set at that point. So thank you, Mr. Chairman.
So as part of this conversation, would you guys like to present your materials and supplies portion? Dirk, come on up. You want to do both sets of slides on this, Dirk, or do you want to tell me what you'd like to do?
Thank you, Madam Chairman, Mr. Chairman. I would like to go over the affordability slides with materials at this moment, if that's okay with this committee.
Okay.
Madam Chairman, Mr. Chairman, members of the task force, my name is Dirk Dykesel. I'm with Blue Cross Blue Shield of Wyoming. Thank you again for allowing us to present and to be before you. I know I stand in the way of lunch, so I will try and be brief. I think what ultimately the discussion that we're having so far this morning is really an issue of transparency. And that's where I think this serves a huge purpose. We'll go through data that shows you there's a wide variance on the underlying charges and payments. So the payments that Blue Cross Blue Shield of Wyoming makes to hospitals specifically in outpatient settings for underlying materials and supplies. These are things that are input prices. What we don't have insight is the actual purchase invoice. We do in ASCs. An ASC is an ambulatory surgery center or a professional setting that's not associated with a hospital. We get the purchasing invoice, and we pay a rate based off of that. We don't do that, and we don't have that in the hospital setting. So when we go through this, I think what this is ultimately showing is transparency into an issue of really there's either an acquisition price issue of critical access hospitals in this state having a struggle, and the struggles are real in the rural setting.
of acquiring these at the same prices or near the same prices as in the ASC setting in the doctor's office. Or there's a price issue, but we don't have insight, and I can't provide data on how those payments ultimately by the insurance company, us, are determined, or how that charge ultimately after the discount is determined at the hospital level for the underlying supplies. So I do want to start off on a quick review, and I think many of us already are there, is we presented last time on the changes, the history of health insurance. We presented last time on why health insurance is the way it is and so different than on the other lines of insurance here in the state. And just a very quick recap on the two most important slides there is that we base premiums on the overall medical costs of the insured population, and they are no longer reflective of individual risk. So as we see here between the premium requirements of how we set our premiums, and then also what is known as the medical loss ratio requirements under the ACA. This is a federal law. It requires us as insurers to spend 80 to 85%, depending on the market, directly on medical care, and the remaining funds then can be used by the insurance company for administrative costs, operations, and margins. What this effectively has done is aligned premiums directly with the underlying medical costs of care. And the reason that we are talking about the hospital setting here is not for any other reason than there's just a very large amount of the money that goes towards hospitals. So we presented here that in 2024, 95% of premiums went directly to medical costs, 53 cents on that dollar went directly to hospitals. And then in 2025, 93% went to medical costs with 51% to hospitals. That decrease in percentages is largely because the underlying cost of claims did go down. We were paying $1.05 in 2024 for every dollar of premium collected. We paid 99 cents on every premium that we collected the next year. So as we increased our premium to match those claims, you saw the percentages then decrease. So we also presented that this isn't a new problem. This is something that has been going on for a very long time. Rising medical costs, rising medical spending has been seen and attributable in this country since 1960. And we've seen that exponential growth year over year. And we provided the statistics that on average is roughly around 6 to 7% year over year increase in healthcare expenditures. We also saw that in Wyoming, and we showed the data from 1990s as far back as we could go that shows that it went from approximately $1 billion in spending across all payers, and then it increased all the way up to $6.4 billion. And this is according to the Centers for Medicare and Medicaid Services. So that's the quick recap of how we got here. What we are trying to do and what I applaud the bringer. Yes, Mr. Chairman.
What I thought was interesting on both your graphs on the expenditures from 60 to 24 and then this last one where I think you're at now is I thought that the line would change significantly in 2010 when the ACA came in.
Well, that's the relativeness of exponential growth, and correct, there isn't necessarily a deviation of that change. It's been relatively stable, and which is why I made the comment that this is not a new problem. Despite regulatory reform, despite regulatory changes, laws, other aspects that we went over this last committee meeting, even techniques and things that payers have implemented, there has not seen a decrease in overall medical expenditures. So despite best policy efforts, this healthcare spending has not decreased.
Okay. Please, Eric.
Well, I think one of the considerations here, and I'd ask you this, is if the ACA had been fully implemented in our state as opposed to piecemeal, would it have made a difference that we saw in potentially other states? I mean, we didn't expand Medicaid. There's been other significant differences in the implementation of the ACA in our state compared to others. I don't know if you have an answer to that or not.
Mr. Chairman,
please.
Mr. Boley, it's a good question. I don't think that we would reflect that change because we have provided two different graphs. One is this one here is the national data. And what we see from the national data is even if you took the nation at large, it's states that fully implemented and the states that didn't fully implement it, well, there's not a decrease associated with the rate of change. If anything, we do see that exponential growth continue. In Wyoming, we also see that, and it's similar to the national chart. The main difference here is the x-axis doesn't go back to 1960. Instead, it only goes back to 1990. So in an effort to just try and answer it directly, I'm not sure that we would see that change because we haven't experienced that elsewhere. So as we talk about the underlying costs and materials, and the reason I think that this has been focused on is that I want to start off by saying that we are very grateful for the services that physicians, that nurses, other medical professionals do in this state. They're vital. We all experience this, but the conversation itself really, if you look at healthcare, there's a triangle. You have the providers that are providing the payments, and sure, we're a part of that. And that would be the second vertice of that triangle. But the most important is the patient. And while access is an important part of that, so is quality. The patient ultimately also bears the cost of each of these services, each of these supplies. And that's what we're focusing on today. With affordability, what we're actually talking about is what is the cost to the patient ultimately. That's what really matters. You see that in the Hospital Association slides, and those points are well taken. Those points are well taken where there is cost sharing requirements. Those creates friction at the patient level. You'll see it even in, I don't dispute that insurance companies, we create friction as well. We absolutely do. So do grants from the Department of Health or even from the state. We need to know as a state whether or not there's allowable costs or unallowable costs associated with those. These are absolutely real. And I want to address that head off right at the start. But when we talk about supplies, what this is an input cost into the cost of providing healthcare. And if you can lower that, that means that you're not changing access. You're not changing the quality of care. You're not changing where you go for care. What we're trying to do is take an input cost and lower that because we do see a very large variation in those materials and supply costs. And if we can bring those down, that seems like an efficiency and an opportunity for this state, something that is actionable here. I don't remember who it was earlier that asked the question. I think it may be Representative Pendergraft that said, what are the things that we can do at this state? You're looking for actionable items. What can we do to help offset the rising cost of healthcare? My answer to that is there's not going to be a single mechanism. It is a very complex system. Healthcare is extremely complex. And if there was a single simple change, it would have happened by now. And a lot of this is also controlled at the federal level. But the opportunity that you have is one, innovation at the state level, and then two, a series of 1 to 2 to 3% solutions that start attacking that overall cost increase. Do not let analysis paralysis get in the way of meaningful change that if you combine together can actually make a difference. And that difference translated and should be translated ultimately down to the employer and the patient level. Because one thing that's not discussed is the fact that your premiums that are paid by employers are absolutely driving up the cost of benefits. And as those benefit costs go up, it's more difficult for employers to provide jobs. It's more costly to provide those benefits to the employees. And it's absolutely a factor. So if we can tack something like this, that is the input driver, that doesn't change the experience of the patient or really the provider or really us. That is something that is meaningful, and I think we can get around. So healthcare is often discussed in facilities, physicians, and premiums. And this is different. We're talking about medical supplies, devices, implants, and equipment. We have asked, what are those costs? So I believe it was Karen that discussed earlier if we need to know or we may not have insight into what those total costs are of the procedure. There's really, really good data published on this in PubMed. And there's studies that have been done over the series of 20 years on just orthopedics. And the reason I pulled out orthopedics for this presentation is because one, it's understandable, and two, there's a lot of information out there on this. So a 2025 study that looked over, I believe it was hundreds of studies of the average cost of a knee replacement since 1990 found that the average cost of the implant alone was $5,000 with a standard deviation of $1,600. Now, if you're going to ask me what a standard deviation is, I'm going to punt over to the very, very smart individual in this room, known as the Deputy Director of the Department of Health. He can explain that in a much more meaningful way than I could. But what that means is that the vast majority of knees in this state, or sorry, the vast majority of knee replacement implants in the nation, it's just that nationwide study, fall within that band, plus or minus from the median there, the average cost of $5,336. Other studies looked at other procedures. They found that in orthopedics specifically, implant purchase prices can range anywhere from 22.3%. And that was for knees, which is the highest volume, which you would see or believe to see driving down of the cost or efficiency gain there because of the volume. And then in other procedures such as elbows, knees, sorry, I already said knees, but also shoulder surgeries, that you'll see that those purchase prices of the implant represent about 49, almost 50% of the total procedure costs. And then finally, in 2020, there was a study that was also released that's citable. It's in the table of authority that suggests that the cost variation likely reflects the advantages associated with higher volume. So as you increase in volume, you would expect to see that your costs come down, the purchase price come down. We see this in wholesaling. So the key takeaway here is that published research suggests that implants and supplies represent a significant cost driver. We're seeing from the data 22 to 50% in orthopedics alone. And this represents an opportunity to improve healthcare through sourcing or strategies that don't fundamentally change things to the patient and don't fundamentally change things to how healthcare is provided. The data I'm providing you here is the cost that we are seeing from ASCs. Again, I'm going to go over what an ASC is. This is not associated in a hospital setting. These are physicians providing surgery in a different setting. And what we're seeing is the data that I had in this previous slide here showing knee replacement implants associated with $5,000 and a standard deviation of $1,600. That's also experienced here in Wyoming in the ASC setting. That means that it's possible, that it's actually happening. You see the cost of these implants being purchased at that national average. So again, that's the study that's in here, and it shows that band, and they're falling well within that. That's the actual costs cumulatively added up. It's the median here in Wyoming. I'm going to show you 5 years of claims data for knee replacements, the implants and supply costs charged and paid. I should say this is paid data from Blue Cross Blue Shield of Wyoming. There's a few caveats I want to get to before we get into it. Specifically, this is our experience. This may not be every payer's experience. It may not be the state plan's experience. It may not be other major health insurance carriers. And certainly there's other payers involved that have different experiences, but this is our experience. And we see that the amounts that Blue Cross pays for implants and supplies for total knee surgeries that occur in the hospital outpatient department is significantly higher on average than those national studies, or that we see in a lower cost setting here in Wyoming. In the following charts, the allowances for supplies are associated with total knee arthroscopy, total knee replacements. On average, the implants represent about 80% of the total supply and implants made to the facility for the TKA. These are based off revenue codes for supplies and implants. You'll see in 2021, the x-axis here, and this deserves a lot of explanation because it is a busy graph. The x-axis on the bottom is every claim for a knee surgery that we paid in the hospital outpatient setting here in Wyoming. And what you see on the Y graph, or the y-axis, is the amounts paid that are attributable to supply and implants alone, not the total cost of the procedure, supply and implants alone. So while we saw in the ASC setting, meaning outside of the hospital outpatient department, in physicians run and independent facilities, roughly and median right around 53 to 5,400, some years higher than that. Absolutely. That is not the experience that we see from the amounts that we pay to hospitals. On the left-hand side, you'll see it starts as low as probably right around $5,000. That quickly escalates all the way up in 2021 to over $80,000 for the supply and implant costs for that same procedure. We then have tried to do exactly what you asked. What are the savings that could be attributable if we were efficient and if we were able to even reduce that? We try to do this in a very, very conservative manner. So I'm going to go over what the blue and the orange and the lines mean. So the blue line you see, that's horizontal. That is the average that is paid, the median, after you throw out the top 10% of charges and paid, or after you throw out the top 10% paid. Then we have calculated the median. And the reason that we did that is because we want to be fair. Not every knee surgery is going to be exactly the same. There is going to be high cost outliers. So we are actually trying to throw those out, saying these are probably due to complexity. And then we have calculated based off of this where that median lies. And if you just moved it down from the variation we had to savings, if you could move the acquisition, what I believe is maybe the acquisition price, to that median, you would bring it down to $288,000 for just knee replacements and the supplies and implant costs associated with that in a single year. That is one procedure. Let me say that again. That's one procedure. Earlier, we talked about roughly about $180,000 that are left on the table because of denials.
Eric, please.
So I've looked at your slides and thank you, Mr. Chairman. So I'm curious, that $288,000, what does that equate to in reduced premiums that will actually be passed on to the recipients?
Madam Chairman, Mr. Chairman, Mr. Boley, I'm going to be very direct in my response. It's going to be based off of what you charge us, because ultimately our contracts are discount off charges. And that's something that hasn't been discussed today. Ultimately, we bargain and negotiate for a discount off the charge that we are charged by each of the hospitals that have that in their contract. Not every hospital is on a discount off charges, but as Mr. Red earlier said, 90% of Wyoming hospitals are on discount off charges. What that means is that there is an inefficiency in the system where you hear subsidization is needed for lines of service that are unprofitable. It is only because they are not charged appropriately. Let me say that again. When you control the price of what you charge, ultimately, whether or not something is profitable or unprofitable, it is based off of whether or not you are charging enough. And that begs the question of if implants and other inputs come down, ultimately, will we see a reduction in the amounts charged to the patients and the insured group? That's the question. And then further on that, what I would even go farther on the saying is, I'm not sure that the payment reflects what is actually the underlying supply costs. I don't know that. I know the amounts that we pay. We don't have insight like we do in the ASC setting. So the question for you all is whether or not you have a price issue or an acquisition cost issue. And that can help you decide whether or not to move forward with the state GPO.
So let's assume that $288,000 is decreased in what you pay. What does that equate to for premium reduction?
Absolutely.
And is there a guarantee that it would be passed on to the consumer? But do we have any actuarial information? If we reduce 2% across the board for total expenditures, what does that equate to for the consumer?
Let me get to this really quick. I'm just going to move all the way to this, and this is the tie to affordability. Because we are regulated, our prices are regulated. The way that we pay and use premium funds, by law, if charges go down and payments go down, we have to. The reason is because of the medical loss ratio requirement, as medical costs decline, that has to be attributable to within 80%. And if we don't meet those standards, we have to rebate the credits back to the consumer. So we absolutely have to meet these requirements. We are already regulated. What I would say is, again, it is not necessarily a question of whether or not this is going to be passed through, because that question has already been answered. The question is whether or not we are being billed appropriately for the actual amounts and the charges. So, and this is, like I said before, I'm not overselling this. This is not something that is the panacea to your affordability crisis, to all of our affordability crisis. But what this reflects, and we can just take this slide alone, is an opportunity to be more efficient, to lead to a lower expenditure of healthcare costs. And if it's not for the insurance companies on the private insurance side, my question then would be, is this variation also reflected to the government payers? Because you have government payers in the state in critical access hospitals that are reimbursing hospitals on a cost-based reimbursement basis. So this is a question you, as state legislators, as representatives of the government, should also be questioning. And if it's not, then I guess then there's other questions that should come out of that as well. And so I want to pause there and see if I've answered Mr. Bully's question.
Well, actually, in response to that, there's a lot of oversight when it comes to cost and cost reporting. And we are audited by CMS many times on our cost report before they're settled. So there is a lot of a difference in what you're talking about between our government payers and our private insurance payers. Secondly, we aren't paid as a percentage of billed charges. We're on a fee schedule with Medicare that they set. And so we're kind of at their mercy as to what we receive in payments from Medicare, as opposed to contracts that we negotiate with insurance companies.
Mr. Chairman, I agree with what Mr. Bully said there. And I'm going to just put it this way. What you are describing is quasi-price regulation. In the government setting, for government and covered individuals, you're describing price regulation, meaning that those folks that have or are covered by government payers, regulated prices through fee schedules is how the government pays. That's not the same in private insurance.
It's not a debate, Mr. Chairman, but what I would say is the regulated prices that the government is paying us is not enough. It's not enough. We're paid pennies on the dollar.
So when we talk about hidden taxes on the whole system, I would start there. So ultimately, I think we've hit a lot of this. And I know that there's a lot here. He asked about savings, and so we'll move to that. Here, this is the amount of savings. It's roughly over a 5-year period, around $2 million on just knee replacement, implants, and supplies alone. If you move beyond this into other orthopedics, and I should also say those metrics are based off of just getting it to the median, Mr. Chairman. And so this is also just getting to the median of what we pay hospitals. And that's roughly about anywhere between $7.2 to $9.3 million a year. Again, I'm not trying to cast this as the panacea. I'm trying to say that if we're going to tackle this issue in the state, because we can claim all day that we can't do something because we're either preempted or the federal government needs to, but if you want actionable items, this moves it in maybe even the smallest of margins, but we're starting to move towards, are we going to move healthcare costs down by 30% next year? I don't think so. I don't think anybody's under that illusion. But if we can start attacking and getting a regression to the mean or a regression on the escalation of that increase year over year, that's meaningful. That's absolutely meaningful. We want to go beyond this and say, if we could get this to the 5th percentile, roughly close to where that top band of the standard deviation would be of what we see in the national setting, and we move this across all different, well, just I should say, here we have about, I think, 5 procedures that we've calculated. We're looking at approximately $21 million in savings on its supplies and implant costs alone in 2025. You take that over 5 years like we were looking at, $21 million adds up really quickly. And so I guess that is what we're proposing here, of just the idea. And maybe it's not the liquor division setting, but what I would say is if we are doing wholesaling and buying for liquor, maybe we should do that in the healthcare setting as well, because we've said it's a government, or at least the precedence there, that this is a governmental function. Mr. Chairman, I'm sorry that I didn't stop there.
No, I think your argument leads to confusion in my mind a little bit, Dirk, in that we're making the assumption, and I'm that then the states, if it was a state-run liquor model GPO, that they could get a better price on devices or durable goods, whatever, than what the GPOs that some of these hospitals are currently participating in. Is that what you're saying?
Mr. Chairman, I don't know that we know what the acquisition costs are for hospitals. We don't have that information. We try to get that information. We don't. We get them for the professional outpatient setting, meaning not associated with the hospital, but in the hospital, we don't. So it doesn't necessarily have to look like the statewide liquor division. What is important here, and I'll just move forward a little bit here, is just saying it's about getting transparency into that. Even if that is where we could get, that is a meaningful change. I do think that a GPO would bring down the input price. And I'll go back to Mr. Bully's question. Is that going to translate into premiums? I guess ultimately it's really going to depend on whether or not that translates into the amounts charged. If we reduce input costs, if we have governmental assistance, if we have tax bases that are all leading towards supporting what are governmental facilities in some cases, nonprofits in others, and for-profits in others, my question is, what is the actual cost and how is that support translating? Because I don't think we have that insight.
So I'm a little bit challenged by that too. Now maybe you're just asking that question as relates to what this task force has started a few months ago. But if that was a question that's existed for a period of time and you have a negotiation process based on their charge master, you would think that in that negotiating process that they would somehow have to provide what those costs are in order to negotiate a cost that you'll pay for claims. So walk me through why you can't get those costs. Because Eric's a bully?
Mr. Chairman, Madam Chair.
No, I mean, is there a regulation there? But it just seems like it would.
Say it.
Huh?
I didn't say it. That's what you mean.
Ultimately, we don't determine the price. I think that's a question we also heard this morning.
It's what? Say that again.
I think what you're getting at is the question we have this morning. We take it off of the charge master in the discount off charges, meaning that we pay a discount off of that price set. The price is ultimately determined how much we pay for hospital services is off of that rate. So the hospital is determining what the price is. How they come to that amount, I can't tell you that. And I don't think that the testimony
That's my question.
you heard is,
Yeah.
I don't think there was a solid answer there that I heard.
Okay. Mr. Red, please.
Thank you, Mr. Chairman, and thank you, Mr. Boley. I think this is a good conversation to have. And, this information is informative and I think important. And when we had the discussion earlier today with Reddy, I think the same thing. It's informative and it's important. I didn't get a chance to say it at the end because, we were running out of time there. But, when we talk about sustaining and supporting primary care, and they talked about that, I want to speak up and say, that's great. That's something we can get behind and we can support. So something like this is a service that's become extremely expensive in Wyoming. And so what we're trying to do is find a way to bring the cost down. And if we can help the hospitals to bring the cost down, it's a way for us to work together. I feel a sense of pushback on this. Maybe I'm wrong, maybe I'm right, but maybe this isn't something that the hospital association is open to because there's other GPOs. But what could we do? Is this because the outpatient service has a, you know, is it being billed on a HCFA and a UB04, so there's a facility fee associated with it? So if it's at an outpatient facility and it's not connected to the hospital, should we talk about how it's billed and whether it should be billed at that rate? Is it because of the implant itself, or is it because of the site that it's being received at? And, you know, if this isn't going to do anything, if it's not because the implant's really expensive, like you said, the guy wants a $25,000 implant. If it's not actually that, then what is it? And what can we do? And how can we fix it?